Magdi Yacoub, and his talk about congenital heart transposition of the great arteries, challenging and dog. Thank you, Professor.
Thank you very much. I have something on the middle of the screen, keeps saying waiting. Is it possible to get rid of it?
I think it's your computer, you just ignore it.
Okay, it doesn't matter.
Yeah.
Well, thank you for your very kind introduction. I'm really honored and privileged to join this incredible group, and I hope to do justice to this talk. Now, my title, as you can see, is Transposition of the Great Arteries, Challenging Dogma. What do I mean by that? I mean that transposition, surgery for transposition of the great arteries has gone through an incredible period of evolution and, to my way of thinking, continues to evolve. And I hope to convince you that this is the case. Next slide, please. Can you get the next slide? Yes. So what I'm going to talk about is what is dogma. It's current wisdom. What's current wisdom? Actually, it can be described as ignorance as well, as some pioneers have talked about. And what I am going to do is to challenge dogma and give you some evidence to the contrary of the dogma, and then come back from current wisdom to current knowledge. Where are we going from here? That is, where are we now? And end up very, very quickly by saying the future, if I can look into the future. Next, please. Now, what is the dogma, the wisdom so-called? The first is that we have reached a stage now where all of us, or most of us, or the current wisdom is that neonatal arterial switch is the way to go, and therefore it is superior. I will try and convince you that this might not be the case. The next is the right ventricle is not capable of supporting the systemic circulation. That's current knowledge or current wisdom. The left ventricle is a bystander in the switch operation and doesn't play a much of a role. Again, I will challenge that point. And then the last two things is that the pattern of flow inside the heart does not really matter. I will try and challenge that in a big way, I hope. And then I end up by talking about prevalence of the disease. Particularly, we're talking about TGA right now, and current wisdom, so-called, has it that TGA is constant in terms of prevalence, both around the world and in time. This is also, I will try and challenge. Next, please. Next slide. Yeah. Now, when we say that neonatal arterial switch is the way to go, it means that this is superior. Now I'm going to challenge that. I'm almost talking against myself because at one time I was trying to champion that, but in a sort of an inhibited way, if you like, when Dwight Magoon, a wonderful man, asked me to write an editorial in the Journal of Thoracic Surgery in the 70s about the case for anatomic correction. What I did write is, although I was for writing the case for anatomic correction, but I actually said that there are at least 7 criteria which has to be satisfied if this is a superior operation. Coming back to that argument, what is superior? It has to satisfy certain criteria, obviously. The most important, to my way of thinking, is that a superior operation should have the biggest impact on the following. First, survival. to quality of life. And quality of life is difficult to quantify. But in the case of transposition, you could say after operation that exercise capacity quantified is a very important parameter of quality of life. Then we need to talk about durability. And in this case, again, it is relatively easy to quantify durability of an operation by how often do we have to reoperate. That is durability. Then the next one is really fun in that we need to look at cardiovascular function. And I will try and show you why I am challenging the switch operation against my will, if you like, uh, by looking at cardiovascular function from our work, but also importantly from the literature. The last one, the most important to my way of thinking, is a superior operation should have a worldwide application, particularly in low and middle income countries where most of the patients are, and they are being neglected. So a superior operation has to take that into consideration. Next slide, please. Now, let us talk about survival. There has been excellent studies in the literature about the very long-term survival after the atrial switch and the arterial switch. And again, current wisdom says that by far the arterial switch has a better survival when compared to the atrial switch. I'd like to really challenge that because it's based on theory more than facts. And in this, there are several studies in the literature which are excellent. But I would like to show you this one, which was published quite recently from the Pediatric Cardiac Care Consortium, where they looked at I think 400 patients and equally divided almost between arterial switch operation and atrial switch operation during the same period. And that was published in 2018. And please note that there is indeed a better survival after the arterial switch operation, but the difference is not vast as everybody have been theorizing. And I will show you some evidence that we can improve the survival following the atrial switch operation to match the arterial switch operation. Because if you look at 20 years from this excellent comparative series, you see that the arterial switch 82, the atrial switch is 76. So you don't need much to get the atrial switch on top if you can or if you like. And I will show you that maybe we should try, and I'll show you how. Next, please. Now, we think of the quality of life, as I mentioned earlier, and it is, hi, Olivier.
Hi.
As I mentioned earlier, that quality of life following an operation like this can be quantified by exercise capacity, and there has been excellent studies about that. And while exercise capacity is better after the arterial switch, but it is not perfect, as you can see from this excellent paper. I think it was from Paul Khairi from Boston Children. And you can see, for example, that the chronotropic reserve is slightly impaired, and also the percentage maximum predicted peak, etc. So it's not perfect. I'll show you more. Next, please. Now, let us go to durability and the lack of reoperation. That's how I define the durability. And that again, from Paul Khairy's paper, showing that forget about the green, because the green is a different condition, which is Tausig Bing. But if you look at the complete transposition of the great arteries with or without VSD, the top line is without VSD, the red is with. You see that there is an ongoing incidence of reoperation. And I tell you why. Next slide, please. So the durability is not as we thought it should be. Most importantly, to my way of thinking, is looking at cardiovascular function. And the dogma again has been that the right ventricle is not suited to support the systemic circulation, and that the left ventricle is not important after atrial switch operation. This is a lovely study by Graham Derrick and Andrew Reddington. And what they did, and there is more actually, this is not the only study, studies pointing in the same direction. What they did is that following the atrial switch operation, they showed that the right ventricle is not to blame entirely for the slightly impaired exercise capacity. And they showed very clearly by pressure volume curves that the right ventricle can improve its inotropic state, as evidenced by the slope of the end systolic pressure volume relationship from the Suga and Sagawa model, both on exercise, but also on giving dobutamine in a dose-dependent manner. And what the problem was is that the stroke volume didn't improve enough to enhance cardiac output. And that has been done by other workers beautifully, both from Czechoslovakia, Germany, and the UK, and other places. And everything points out that the inflow to the left ventricle is impaired, and it is the filling which is the problem, not the ejection. So, more about that. Next, please. Next. Sorry. Now, this is quite interesting indeed. We've been interested in the functions of the aortic root, which again has been neglected for a long time. But the more you look, the more you find. So, that's a recent study, the top curve, showing that dilatation of the aortic root continues after the arterial switch operation, even if it is performed in neonatal life, and the absence of aortic regurgitation goes down, and that there is progressive incidence of both dilatation of the aortic root and aortic regurgitation in the lower curve. Then there is a Japanese study, which is excellent, showing, because the aortic root actually have many, many functions, which we have been studied at our center for years and years. And one of them, which has been studied at Royal Brompton in particular, is the reservoir function. And that is impaired after the arterial switch, as in this Japanese study, which is superb. In addition, the coronaries are, and that's not shown on this slide, obviously, the coronaries are denervated, and that might have the patients could get ischemia without having angina. So there are a lot of things which add up. Perhaps it is not the utopia we were thinking of, the arterial switch operation. Next slide, please. How am I doing for time? I'll try and speed up a bit. The next point is that the dogma again says it doesn't matter how the blood, the pattern of flow does not matter so long as that the hemodynamic, the pressure and flow are normal. That's not so, because the more you look again, as in this paper, which was published in Nature by Philip Kilner and myself some time ago, showing the elegance of the asymmetry of the flow in the right atrium and how it goes round and waits for the tricuspid valve to open. So pattern of flow does matter. Next slide, please. And that's determined by 4D MRI. And that's a busy slide, actually shows you the modified mustard. More about that in a minute. And it shows you that if you modify the pattern of flow by this new operation, which was described from the Aswan Heart Center, and more about that in a minute, you see you can normalize the pattern of flow both in the atrium and in the ventricle. Time will not allow me to go through that, but you can see the difference between the classic mustard operation higher up and on the left side, and the modified mustard. More about that in a minute. Next slide. Now, more dogma. The people think that the prevalence of transposition is constant. And as you can see in different countries and also in regions, and also that it is constant with time. Both of these assumptions, if you like, or you can see that it changes over the years, particularly VSD, and that also there is a regional variation in the prevalence, with Africa, for example, showing much higher incidence of or prevalence of transposition. So all that needs to be studied. What's coming now, next please, is next slide, is that the global burden of disease, and joining that group from Seattle, shows that, my God, there is a lot of variation in the prevalence of both the prevalence of the disease, but also in mortality and in DALYs, disability adjusted life years, in different countries. All that needs to be studied, and then there will be more publication coming up in JAC from the global burden of disease in congenital heart disease. And I'm part of that, trying to clarify what's going on. Next, please. Next. And that's from the same studies of global burden of disease. Again, shows you that again, we're looking at DALYs, disability adjusted life years, and it varies in every country. If we limit ourselves to congenital heart disease. All of this has to be studied in details if we can address the global burden of each specific congenital heart disease. Next slide, please. I need to move a bit faster. I don't want to take over time. Now, I move into current knowledge. Where are we now before we move to the future? I've tried to challenge the dogma which we have been living with and try and move into a better or a more evolution, if you like. So my colleagues and myself at the Aswan Heart Center, we worked very hard because we had a lot of cases for patients with transposition. Many of them were neglected, came at different ages. Many had all sorts of complications, pulmonary hypertension, infections. So we devised this method of modified mustard, and they'll talk a bit about this now. What are the advantages of the modified mustard? The most, as we go down, it is applicable in all parts of the world because you don't need to, for example, we can do it in young age, but you can do it in so-called neglected cases, presenting after the first weeks of life, or even patients which we see in Aswan coming at 20-year-old, really very badly disabled with simple transposition. And then that's what I mean by salvage neglected cases. And what are the modifications? The modifications are, we tried very hard to have restore the function of the atria and the enhance filling of the left ventricle and therefore improve the cardiac output through impairing the magic stroke volume. And we believe very strongly, actually, that although we have not followed that up for 30, 40 years, that this pattern improvements could enhance both the survival and the quality of life, and we are systematically moving to do that. The most important, as I come to it, is that this type of operation will and should have a bigger impact worldwide on the overall problem of transposition of the great arteries. Next slide, please. I'm nearly there. This is the operation. Also, the incision is low down on the atrium, avoiding coming near any the SA node in the conduction system. And there are inclusion of most of the contractile part of the atria, particularly to the left atrium. You can read that in the publication by Hatem Hosni and colleagues from Aswan. Next slide, please. Now, this is the Aswan experience. And as you can see, we still, the Aswan group, use the arterial switch operation in big numbers, like 100 a year. They can do 2 or 3 in a day sometimes. But there is evolution that's as shown by the blue lines. And up till now, I think the figure for the neonatal arterial switch is over 600. And that's being analyzed. The orange is the modified mustard. And importantly, if you look at the survival of simple transposition using the both simple and with VSD, there has been no operative mortality in over 115 patients or so. The mortality has been all in pulmonary hypertensive patients where they were having salvage operations. So the operation is very safe. You can do 110 patients with no mortality. And if it is simple transposition, that goes on. There is no mortality in the first 5 years. That's refreshing, actually. And that is for a developing country shows you what can be done and what should be done. Next, please. And this is the pattern of flow. Above is a classical mustard. As you can see, 2 rigid tubes or flow pattern into the left ventricle. In the bottom, on the left side, you can see nice flow in the atrium and nice flow in the left ventricle with vortices and beautiful flow. And we think that is going to improve survival in the future. Next slide, please. Importantly, this is the so-called modified mustard. We have managed to restore atrial function. And when I say atrial function, I mean that all 3 components of atrial function, which is the reservoir, the conduit, and the contractile function. And that is reflected in the pattern of filling of the left ventricle, but also of the right ventricle. Next, please. And that is, you can read it in the paper by Hosni et al. So I conclude by saying that evolution of strategies for treating transposition of the great arteries seem to continue, and the challenging dogma is indeed useful, and end up by, of course, saying that long-term follow-up is necessary for validating these predictions. Thank you.
Thank you very much. Thank you.
Oh, before I finish, sorry, can we see the final slide? Sorry, I beg your pardon. Can we bring the final slide?
Grace?
Yes, of course. I'm doing that.
It can be after conclusion. Can you put it up, please? Sorry. Just I have to thank and give credit to the surgical team, Hatim Hosni and Ahmed Afifi. And on the right side, you see the team of biomedical engineers was working on the hemodynamics, and that has been led by Heba Adib. And you can see all these young, enthusiastic guys. That's what makes it so exciting. Thank you.
Thank you very much. I think it was an amazing presentation, and the main message is that we still continue to learn from Pioneer, and Pioneer that have created an enormous number of talented surgeons and people that still continue to help child all around the world. So my big pleasure to have you here. Now we continue and we move to Professor Pedro Del Nido, who is the chair of the department in cardiovascular surgery at Boston Children's Hospital. He don't need again too much presentation, and he will talk about complete atrioventricular canal defect. And welcome, Pedro, and thank you very much again. If you can, yes, thank you. Pedro, you have to unmute. You are muted. Okay.
Sorry. I apologize. Can you hear me now?
Yes, perfect.
Okay. So I was just saying that it's always one of the biggest challenges is to follow someone like Professor Yaqub, who challenges us to think. That's probably the biggest challenge we'll ever receive, is to think about what we do every day and what we assume is the correct thing to do. And transposition is a great topic. I would say that the task of talking about complete AV canal defects is another one. It's been a lesion that's been around for a very long time, but yet probably causes us tremendous amount of consternation. It's probably one of the hardest operations for a young surgeon learning to do congenital cardiac procedures. The incidence amongst congenital heart defects is relatively low, but yet if you look at the impact on the outcome of these children, it's huge. It's about 4.4 to 5% of all congenital heart disease. It's a tenth of patient per 1,000 live births in the old New England studies. And the history of the management of complete AV canal is the history of congenital cardiac surgery. It started with the early descriptions by Edwards in the 40s. Lillehei was one of the first ones to really talk about repairs, but using this cross-circulation model. And this is a hand drawing that was done showing the cross-circulation concept. And then really the systematic approach, I should say, to analyzing the most critical component, which is the valves. And I think Rostelli's contribution is singular in the sense that it focused us away from fixing the hole, and really started us thinking about how do we repair the valve. And what I'll argue with you is, even though we don't really use this classification anymore, at least we talk about A and C, rarely do we see the B, but nevertheless, I think his message, which is this is a valve disease, still resonates today. And I'll show you a little bit about that. Why is that important? Well, our methodology for analyzing this relies on real time and as much temporal and spatial resolution as we can get. Traditionally, that's been two-dimensional echo, two traditional views. This is the four-chamber with gradual scanning up anteriorly so that we gradually begin to see the left ventricular outflow tract here. And then the cross-sectional image, which for the surgeon is quite important because what it tells us is where the balance is of the AV valve, at least, over the two ventricles, but also more importantly, where the papillaries are. And the papillaries and the subvalvular apparatus plays a huge role in our ability to actually repair these valves. Fortunately, the pattern is relatively common. Two usually reasonably well-spaced papillaries are sufficient for us to be able to do an adequate repair without worrying about the inflow. 3D echo, I think it hasn't been applied as much, but I think its role really needs to be expanded. This is a three-dimensional echo in a patient who had regurgitation after the repair. And what it's telling us, if we're thinking about repair, there are many, many components to the problem here. There's prolapse, there's restriction, and this kind of snapshot view is what we need to seek. On the preoperative assessment for the surgeon, we look at a number of factors. Probably the most important is really the papillary muscle location, because that determines how much of the way of leaflet mobility we have, particularly on the left side. But usually leaflet mobility is something that's very difficult for us to determine, mainly because our views are so limited. The four-chamber view only gives us a snapshot in one plane, but we really need to scan throughout this valve in order to detect areas of restriction. And restriction of leaflet mobility by accessory cords is probably, I would say, at least in my experience, one of the more common causes of late regurgitation. The annulus diameter, position over the septum, and mechanisms of dysfunction all obviously play a role, but these two, the first two, are probably the more critical factors that we look at. We think in terms of partial, transitional, and complete canal. I would say we also need to think about a strategy for unbalanced canal. And at least in our center, we focused on this last group. I'll mention very little of that at this on this presentation, and just towards the end. I'm not going to talk about partial AV canal because wasn't what I was tasked to do. I'll mention a little bit about transitional AV canal. And the reason for that is that the AV valve is still a problem in transitional. And often the way these children present are dysfunction of this AV valve. Managing the AV valve in a transitional canal can often be challenging. And these can be some of the hardest valves for us to repair. The traditional method of repair is very similar to that of a complete AV canal defect, except that the VSD often is closed as a primary procedure. This is an echocardiogram example of a case where a patient had a transitional AV canal defect. In this case, there is a regurgitant jet. Fortunately, that regurgitant jet is in the central portion of the valve, so that it's relatively straightforward to fix this. The size of the inlet valve on the left is equivalent roughly as the inlet valve on the right. This is that same patient with regurgitation. This is a view looking at it from the surgeon's side. This is the common AV valve. What we're doing here is we're actually establishing where does the ventricular component of the septal defect end, and where does the atrial component, which is out here, begin. Often that can be very confusing when you have a valve that's totally collapsed and the heart is empty. Establishing that at the beginning is very important. And this is one of the steps that we take early on, is we position the two opposing leaflets as the first step. And once we've done that, then we decide what to do about the interventricular communication. Most of these can be closed primarily, and the end result can be actually fairly satisfactory. Complete canal adds another layer of complexity, and that is, what do we do and how do we close the ventriculoseptal defect? And here's where there's an enormous amount of literature on how to do it. And if you see in a series of surgical journals many ways to solve a problem, it should give you the first hint that none of those techniques are applicable to every patient, and none of them are perfect. So it's important to understand all the techniques and at least the concept behind them, because they will apply in different cases to different patients. And I'm going to show you some different approaches that people have taken, some that I use, some that my colleagues use, and some that have been described in the literature. We'll start with the single patch concept. The single patch concept is probably the first one that was described. And the simple reason is that it actually is the easiest one from the standpoint of closing the hole. It's easier to understand. The valve is not in the way, but it does require a tremendous amount of judgment call. And the judgment call, it starts at the beginning. Where do you partition the valve? And this again is where deciding on that location at the beginning of the procedure is so critical. So positioning the two bridging leaflets at the zone of coaptation. Often this has to be done by floating the valve. And this is one of the techniques that all surgeons, I think, undertake, is they float the valve in a passive fashion with fluid, but nevertheless, it gives us a better idea of what actually is coming together. Once you put traction sutures and you hold that valve in that position, then that allows you to make a decision as to where your cuts are going to be. Because what you're going to do is you're going to split that valve both in the inferior component as well as in the superior component. And that then allows you to put in your patch. And then the final step is, where do you resuspend this valve? Resuspending that valve up onto the patch is the next decision. The size and the shape of that valve, or the patch, a lot has been said about that. I think it's probably more important, rather than the shape. The dimensions that are critical are the crux to outflow dimension. Making that the appropriate length is probably one of the biggest mistakes that people make, or more common mistakes that people make at the beginning of their careers. Most often we make them too big. What happens is that we run out of leaflet to cover the central portion. So this dimension, the width, should be determined at the beginning of the procedure. Not just where the leaflets are, but this distance from crux to outflow should be determined, and that determines the size of your patch. How big your VSD is, how big your atrial component is can vary. And obviously, if you're doing tetralogy as well, that's another area that I think is going to be covered in the next presentation. That patch is completely different. So here's an example of a case where a complete AV canal is being done. This patient has attachments to the crest of the septum, both in the superior and in the inferior bridging leaflets. And what the surgeon is doing at this point is deciding where are the two leaflets coming together. They've been pinned together by these sutures. I don't know if you can see them up here. And that will determine where the incision is going to be. This sucker right here is in the coronary sinus. Conduction tissue is at the crux of the heart down here. So the incision has to aim towards the right. The advantage of this single patch technique is that it allows you to get rid of tethering attachments to that bridging leaflet, particularly on the left side. And the other advantage is it allows you to get rid of subaortic, or at least potentially obstructing attachments between the underside of the valve and the left ventricular outflow tract. So even though this is a challenging procedure to do, which is this single patch technique, It does offer significant advantages for visualization, but it also requires a significant amount of judgment. The patch, in this case, is pericardium. You can use Dacron, and I'll show you another example of Dacron for this patch. The patch, in this case, is a single patch. The first part of it is just a ventricular. I'm going to speed up through this a little bit, just so that we don't spend a lot of time. I think most people know how to do this. This component of the repair is simply sewn onto the crest of the septum, both superiorly and then inferiorly. And then the final step is, once you've done the ventricular component, then you're going to trim the patch so that you can get all the way to the crux. And the crux of the heart is down here, down at the bottom end of your incision. Once you've sewn that in, we find it very helpful to actually mark where those leaflets ought to be. And that ought to be where you determine the height between the crest of the septum and the coaptation point of the leaflets. Often the echocardiogram will give you that information ahead of time, or you can measure it at the time that you actually are doing the procedure. But marking the height has been very, very helpful in deciding where to actually position that valve. Because if you position them up too high, those leaflets are tethered and they will not coapt very well. And also the central portion you've already determined at the beginning of your procedure. So I'm just going to keep advancing through here because this part is actually fairly standard. Once you've done the reattachment, then the next step is deciding how much of this zone of coaptation or cleft you're going to close. In most cases, you need to close the base for sure. And how much you close at the beginning really determines where the attachments are of the cords, where they end. My preference is to continue all the way down near where the cords are attaching. Keep in mind, though, that the cords attach to different papillaries. The inferior bridging leaflet attaches to the inferior papillary, superior to the superior. The further down you go towards those cords, the more you're going to tether the tip of that leaflet, and the more you're going to restrict the mobility. So what do we do about that? Well, in our center, we also add a posterior suture support. This is resorbable suture. It starts from below the conduction tissue, so on the left ventricular side, up the annulus, all the way up to the outflow tract, and it is tied over a Hagar dilator with a Z-score of 0, so that the valve is not restricted in any way. But what that does do is that, at least temporarily, at least the early period after surgery, the posterior wall of the left ventricle is supported by that suture. I'm not going to show you the atrial component, but this is the end result in this patient with a valve that's reasonably well supported. That's the single patch technique. The two patch technique, which has also very commonly used, as the term goes, uses a separate patch for the ventricular component versus that of the atrial. The advantage is that you don't have to split this valve, at least not at the beginning. You will still need to split this valve at some point. So you don't avoid the problem. What you do is you defer it to the time that you're actually closing the rest of the ventricular septal defect. That is, you're attaching the top of these leaflets to the top of this patch. And so the decision about where to make the attachment is still the same. The difference is you're not cutting it ahead of time. And really, that's the only difference. And in for some surgeons, that makes it easier for them to manage the valve afterwards. I would argue that for many surgeons, that actually makes it harder, because you already stuck a patch underneath here, and now you have to, with tethered leaflets, you have to somehow bring this central portion together. I started doing the two-patch technique. I still do it in most cases, but it requires much more judgment call, much more pre-planning, and I would say probably causes more problems than it actually solves. Nevertheless, that is the concept. It's the same process, but now you have to slide this valve underneath these tethering attachments, which is always challenging because that actually restricts the mobility of particularly that inferior bridging leaflet. And many of the causes of recurrent regurgitation or regurgitation early after surgery are distortion of particularly the inferior bridging leaflet with this technique. This is an example of a hybrid, a procedure where we actually do it both ways. In other words, what we're doing here is we're going to use a two-patch technique, and we're going to make the same decision, judgment call, as to which leaflet goes to which point of this is the inferior bridging leaflet down below. We're floating the leaflets up, so we're trying to decide what goes together. We're going to mark where those leaflets come together with a suture, and that's going to determine the position of the central portion of the zone of coaptation. Once you do that, then you can determine, you've now decided the right half of your valve, and posteriorly, as you can see down here, the left half of your valve. The next step in this method is to then go ahead and close what we would call the zone of coaptation on the right side and the zone of coaptation on the left side. This is done before you close any holes. So this is all done at the beginning of the procedure. This is what's different in this approach. And we found it a lot easier to teach people to do this operation. So now we've closed effectively most of this zone of apposition. Close it on the right side. We're going to put sutures on the left side to close it completely. These are just the interrupted sutures. This is all done with interrupted sutures. This is the whole entire zone of apposition is being closed. Now we split the leaflet. And you can say, well, this is backwards. You have it backwards here. No, not really. You're still making the same decision as to where you're going to attach your patch, except now you're going to actually divide that leaflet into left and right half. And now you're going to put in your patch. The advantage is it gives you the ability to get rid of the tethering cords. I'm just going to go back here for a second. These are the tethering cords that keep this inferior bridging leaflet from floating up. Now you can see them. You can divide them on the left side. And if they're edge cords that you need to keep, you can keep them. If they're support secondary cords that you don't think are necessary, you can get rid of them. That's the advantage of that of this approach. Then the rest is the same as a two-patch technique. You're putting in in this case, a Dacron patch on the ventricular side, again, you're going. That patch is going to have to be trimmed, and here is the process of trimming this patch so that you bring the leaflets. Now, instead of sewing it to a single patch, you're going to sew it to the crest of this VSD patch, bringing the two bridging leaflets, the right and the left component, suturing them to the crest of the patch. And then the final step is to add the atrial septal patch. We still do the posterior annuloplasty in these patients, again, with PDS, with resorbable sutures, and typically it's 6-0 PDS. It's only partial. And then the rest is really closing the atrial level communication with a primum patch. Here is where the conduction tissue is probably the closest to your repair, near the coronary sinus, and avoiding that obviously is a critical part of the procedure. Finally, I think we have to acknowledge the other approach that's been proposed by, particularly from Australia, which is the modified single patch technique, where the bridging leaflets are simply sutured to the crest of the septum, in this case with interrupted sutures. The concept is, again, the same. You start off by deciding where your leaflets come together. Then you pass sutures through the leaflets and through your patch. They're all tied down, and that effectively closes both the VSD and partitions your valve. You still have to close the zone of coaptation in a way that gives you competence. However, the advantage of this is that you don't have to put anything underneath these leaflets. You don't really have to cut the leaflets. You still have to decide where this patch goes. And so you never, ever avoid that problem. Finally, I'll say one quick word about unbalanced canal, and that this is one of the more common operations we do right now in biventricular conversions are patients who have undergone single ventricle management. This is an example of one where they had a so-called unbalanced canal simply because this component, the left component of the AV valve, was substantially smaller than the right component of this AV valve. And this patient underwent a Fontan procedure. Well, in fact, you can partition this valve. In this case, the ventricles themselves were actually of normal size. They were effectively normal left ventricle, very dilated, supernormal right ventricle. So yes, right ventricle much bigger than the left, but the left ventricle was of adequate size. And in this case, this patient, by using the same technique, now we have a much bigger left AV valve. There is a secondary orifice here, which serves as an inflow, but still functions as a good valve. And then this patient was able to have their Fontan taken down. This is what you typically would see in a unbalanced canal, and that is what we call a parachute type of valve, where all of the chordal support for this orifice are going to a single papillary. Well, that's not necessarily something that will cause stenosis. And in this patient, there was no stenosis after this procedure. So I'll end there by summarizing that complete AV canal defect is probably one of the more challenging lesions. Our thinking about this was first organized by Rastelli because he focused us on analyzing the valve. And that probably was his greatest contribution. We have to go further. We have to understand how to repair that valve. We need to understand the location of the papillary muscles and how that determines how the valve functions. But overall, I think that this is still an operation that really should be thought of as a valve reconstruction operation. Closing the holes is really has many, many ways of doing it, but reconstructing this valve is really the key to the operation. The surgical techniques that you choose can vary, and some are applicable to some patients and others to others. We use all three, actually, at our center. This modified two-patch technique, which I showed you the video of, we find it useful in the sense that it's easier to teach and for people who are learning to do this operation, in that it totally focuses them on first fixing the valve and then deciding how to close the holes, which has many, many advantages to it. And I think we all have to recognize how the AV valve functions postoperatively is really what determines the long-term outcome. It's not the holes, it's the valve that really determines the long-term outcome in these patients. So with that, I'll end. And again, thank you all for the invitation to participate in this symposium.
Thank you very much, Dr. Donido. It was very interesting. We are going to see on the break later how our audience is distributed, but mostly we are pediatric cardiologists or intensivists. So for us, it was an amazing talk to understand better all the surgical techniques. We really appreciate that. So now we are going to move forward and we are going to continue with AVSD, but when we have association with tetralogy of Fallot. So we are going to have now Dr. James Tweedale. He is from Cincinnati Children's Hospital, where he is the director of the cardiothoracic surgery and the director of the congenital heart surgery fellowship program. And he is also a professor of surgery and pediatrics at the University of Cincinnati. Thank you very much for joining us.
Thank you. Thank you very much. And I really appreciate the invitation. I'm going to share my screen now. And also I want to thank you for changing the order. And I actually think this will work out very nicely as a follow-on to Dr. Del Nito's excellent presentation on AV canal. I've been given the task of discussing tetralogy of flow with complete atrioventricular septal defect. I have no disclosures. I'm fairly certain that Aristotle knew nothing about tetralogy of flow or a complete atrioventricular canal, but I think this quote that's attributed to him fits, that the whole is greater than the sum of its parts. It might be relatively easy to think of tetralogy of flow with complete AV canal as basically adding those two procedures together, which are relatively well understood by most congenital heart surgeons. But in fact, I think when you combine these two, you get something that's actually significantly more complicated than either one alone. The goals are pretty straightforward. It's to septate the ventricles in the atria, end up with competent and non-stenotic atrioventricular valves, and the relief of right ventricular outflow tract obstruction. The challenges are great. First, the common atrioventricular valve of a patient with tetralogy of Fallot and complete AV septal defect is smaller than the typical patient with a complete AV canal. And I think this, and I'll show this in a minute, is due to the decrease in total volume that the heart is exposed to in early infancy. And as a consequence of this, more precise partitioning of the common AV valve is required. We don't have the luxury of excess valve tissue, and our ability to affect competence by annuloplasty procedures is somewhat limited. The exposure of the outlet extension of the VSD is also very challenging, and any residual lesion, particularly left or right AV valve regurgitation, is poorly tolerated, especially in the face of pulmonary regurgitation, which of course is common after relief of RV outflow tract obstruction. This is an example of two patients. Both are infants. Both are about 5 kilograms, both with Down syndrome. And one is a double outlet right ventricle with an atrioventricular septal defect, and the other has tetralogy of Fallot with an atrioventricular septal defect. And you can see here the patient with double outlet has minimal RV outflow tract gradient compared to the patient with tetralogy of Fallot and atrioventricular canal. This is a picture of their en-face view of their common AV valve. And you can see here the anterior bridging leaflet and the aortic valve is shown in both examples. But if you look at the size of that anterior bridging leaflet and the annulus of the common AV valve, you can see that the volume loaded patient with the large cardiac silhouette has a much larger anterior leaflet than the child with tetralogy of Fallot and AVSD. And I think that adds to the complexity of the partitioning. So most patients with tetralogy of Fallot and atrioventricular septal defect have a Rastelli type C AV canal defect, as shown here with a free-floating anterior leaflet. And when you septate that in tetralogy of Fallot with AV canal, in fact, the septum is running obliquely, so that you're, even in this situation, the best of all possible worlds where you might have a large, well-balanced defect, you're going to be stealing a little bit from that the rightward portion of that anterior leaflet. And I think that's shown nicely here in this illustration from the operative techniques with Dr. Reddy as the senior author. And they're trying to show you here where when you place the ventricular septal defect patch and the corresponding position of the septum, that you are actually stealing a little bit from that right-sided AV valve. Sorry, I'm having a little trouble advancing the slide. So I thought I would contrast the two types of repair techniques, and this is it's very nice to follow Dr. Del Nito's excellent presentation, because the the two strategies for repair are to adopt a two-patch technique or a one-patch technique. The two-patch repair was nicely demonstrated in Dr. Del Nido and Dr. Amani's monograph and operative techniques. And basically, you retract the anterior leaflet, you measure the patch appropriately, and then secure it to the interventricular septum, and then pull the leaflets back over the patch and secure the leaflets to the appropriate division site. Exposure can be challenging. It looks relatively easy when you draw it with the retracting the anterior leaflet, but in fact, it can be pretty challenging to do that. And as is commonly done, in fact, it's easier to see through a ventriculotomy. So a lot of times, I will, and as shown in this monogram, secure the VSD patch, and then secure the outflow portion of the patch via exposure through ventriculotomy. To make this even more challenging, some surgeons will even divide the anterior leaflet. This is a paper from the group from Melbourne, and in this case, they actually detached the anterior bridging leaflet from the annulus in order to expose the outlet septum and the outlet portion of the VSD, and secure the VSD patch that way, and then pull the leaflet back over the patch and resecure it. This is certainly innovative, but does also risk some distortion of that anterior leaflet. This is just a couple of quick clips. One of the important things, as Dr. Del Nido mentioned, was precise measurement of the patch. That's generally done after filling up the heart and taking a look at that common AV valve. And as he correctly pointed out, the most common mistake is to make the patch a little bit too broad. But you want to have this portion corresponds to the common AV valve, and then you have an additional portion that corresponds to the outlet extension of the VSD. The diameter of this portion, typically a good rule of thumb, is that this should be equal to the diameter of the ascending aorta. One other way to get exposure of that outlet portion is to actually use your VSD stitches, some interrupteds here, to actually pull on, and you can get exposure that way. Those are just a couple of little tricks. The one patch repair involves dividing that anterior leaflet, and again, this is provides excellent exposure of the outlet portion of the VSD, but one has to be very careful about where that incision is made, and not to steal or cheat either side. You can see there are cords that come to the edge of the leaflet right where the incision will begin, and then you would follow the septum, and that's shown here nicely in this in the monogram by Reddy and Darren, and you secure the patch to the outflow while exposing it through the incision, and reapproximate the leaflets to the patch. I'm going to show a quick video of that technique. This is a 5-month-old, 6-kilogram male with Down syndrome, tetralogy of flow and AVSD, that was admitted with hypercyanotic spells, and we felt he was of appropriate size and age to go directly to the operating room. Here's the atriotomy. I like to do a fairly extensive atriotomy in order to expose this. Here we are dividing some of the parietal and septal bands to relieve some of the RV outflow tract obstruction. And then we're measuring the patch, and we end up with this flow test here. and identify the points of the anterior and posterior bridging leaflet where the division of the leaflets will begin. Now we're dividing the posterior bridging leaflet. That's relatively straightforward. Dividing the anterior leaflet requires a little bit more care and reassessment as you're doing that. Now you can see the VSD is exposed here. I used a Gore-Tex patch in this situation. This patient had a large ventricular septal defect with the VSD extending posteriorly. I do like pericardium. I'll use that. But this was a very large VSD, and I have concerns about pericardium shrinking over time. And I've just found the Gore-Tex to be a little bit more reliable when the defect is large, particularly with a lot of posterior extension. So that outlet extension is secured to the outlet portion of the VSD, and that's shown here. Again, this should be about the size of the ascending aorta. The ASD portion is very large. And then this will be the part that the bridging leaflets will be attached to. And now we're going to secure the posterior part of the patch to the posterior part of the ventricular septal defect. And then that's brought out just to the right of the annulus and septal junction. And then the bridging leaflets are reapproximated to the appropriate level of the patch. And it's the best way to assess that, I think, is to look at the anterior and posterior bridging leaflet cords on the right side. That gives you an idea of how tall that portion of the patch should be. We're using pledgeted sutures here. They have bovine pericardial pledgets, and they're passed through the from the left side to the right side. And then the little bit of cleft that's left on the right side of the patch is closed with interrupted Gore-Tex suture. I'm using that as well to close the left-sided cleft. I think this is less likely to cut through the delicate leaflets, and I like using interrupted suture as it doesn't tend to bunch up the anterior leaflet. And then the remainder of the patch is secured to the atrial septum. In this case, the coronary sinus was placed on the left side of the patch to decrease the risk of injury to the conduction system. We did make a small fenestration, and now we turned our attention to the outflow tract. I performed an incision in the pulmonary artery and in the RV outflow tract. I was hopeful that we might be able to do a valve-sparing approach, but was not convinced that the annulus would be satisfactory. And as you can see here, I wanted to get close to a z-score of 0, but made a small transannular incision and then completed this with a pericardial patch on both the main pulmonary artery and the outflow tract. As satisfied with the result, the left AV valve functions very well, as does the right, and the baby had an uncomplicated postoperative course. As mentioned in the video, if valve sparing approaches, or more accurately, I think, annular sparing approaches, have found a role in repair of tetralogy of flow and AV canal, just as they have with tetralogy of flow. This is a paper from Toronto summarizing a recent experience there. And patients, not surprisingly, who had pulmonary or annular preservation had a slightly lower risk of requiring a reoperation at 15 years. And another strong advocate of the annular sparing approach is Emil Basha from Colombia. This was a recent summary of their experience. 20 patients, 14 had valve sparing approaches, but as anticipated, the patients who had the valve sparing approach had a larger RV outflow tract and annulus, pulmonary valve annulus to begin with. None of the valve sparing patients were shunted preoperatively, but despite that, and despite sparing the annulus, there was no difference in their reoperation rate. Again, as Dr. Del Nido mentioned, there's been some enthusiasm in the last decade for the approach of Nunn and colleagues using no VSD patch component. That is really not appropriate for AV canal with tetralogy of Fallot because of the outlet extension. That would be very challenging and probably cause a distortion. But if you have a shallow portion of the posterior VSD, which is common, you can use perhaps a small VSD patch to just take care of the outflow tract. That is not a full VSD patch. They've termed this a 1.5 patch repair, which might be suitable for some patients with tetralogy of Fallot and atrioventricular septal defect. I'd like to review some of the outcomes with this lesion. This looks like a fairly busy table, which summarizes a series going back to the 1980s, but I'll take you through it here one step at a time. The first thing I would point out is that this is a relatively rare lesion. Even busy programs like Boston Children's Hospital cobbled together 61 over a 29-year period, and that seems to be a sort of a general rule of thumb that even busy programs only see about 2 of these patients per year. And there is significant variability in their anatomy. So interestingly enough, I think this is a pretty rare lesion, even at busy programs. Palliation is commonly performed. Only this series from Leiden in the Netherlands had less than a 33% rate of palliation. Some use it routinely. The 2-patch repair dominates around the globe, as you can see here. And so, again, that's probably the most common strategy. Nevertheless, I think the 1-patch repair does have some advantages. Still, repair is done relatively later than many of the other lesions we routinely take care of. Only the series from Chicago and the recent series from Shanghai, the average age was less than 1 year of age. Most of the time, these patients are repaired at about a year of age. Despite all of our capabilities, the mortality is non-trivial, and although it has, and there is some late attrition as well, although this has improved in some more recent experience. At least we have more series with 0% early mortality. Reoperation risk is still relatively common, as you might anticipate. Is probably similar to that of the combined experience with isolated AV canal and tetralogy of Fallot. This was a nice meta-analysis done by the group from Novosibirsk in Siberia. And they looked at the impact of palliation prior to complete repair of tetralogy of Fallot with atrioventricular septal defect. Not surprisingly, I think, there was no difference in 6-year survival, although patients who were previously palliated had an increased risk of right ventricular outflow tract obstruction. Freedom from outflow tract obstruction being favored in the primary repair group. Again, this probably reflects the beginning anatomy. Patients who were palliated were more likely to have significant RV outflow tract hypoplasia, and that probably set them up for a reoperation later. Although many of these patients will get through the neonatal period without the need for palliation, they sometimes require palliation even at a couple of months of age. As we all know, there are interventional strategies, RV outflow tract stenting and ductal stenting, which have been used to help improve pulmonary blood flow until these patients are a little bit larger and repair is a little bit more straightforward. This is a paper that was first authored by one of our interventional cath fellows here. This is when she was in Dublin, Ireland, showing their experience with stenting of the RV outflow tract. Ductal stenting can also be used in newborns with ductal dependent pulmonary blood flow, and any of these strategies might ultimately have a bigger role to play. There's currently a PHN, Pediatric Heart Network study that is going to look at this in a systematic way. And that study is just about to get started. So, in summary, I would say that this is a rare lesion. It remains a challenge that is more than the sum of its parts. It continues to have a non-trivial early and late mortality. Palliation and delayed complete repair continue to play a role. And as Dr. Del Nido said, for complete AV canal defect, I would also say that surgeons should be familiar with both the 1 and 2 patch repair. Sometimes a patient's anatomy fits one or the other of these, and it's a good idea to have a good working knowledge and with both of them. And I will end it there. I want to thank you for your attention. It's really been an honor to be invited to participate in this meeting, and thank you for the opportunity to speak to you today.
Thanks, Jim. I think that your presentation was tremendously learning for all the people that was following your presentation. I think that, as you say, is not. It seems to be rare, but I'm sure most of the people have faced in his life, and I think that your review and the way you view this disease after also the presentation of Pedro was amazing to put together both technique and think and experience. That is something that probably we miss due to number of meetings dedicated that are going down and not a real good connection, continuous education of this type of disease. So thanks again. It was tremendously teaching and learning for all the people. The comments on YouTube and on the chat are impressive. So thank you again. And we go now to Yves Dudechem, who is is working at Royal Children's Hospital in Melbourne in Australia, and after a few years became a deputy director of the cardiac surgery. He is now established as a leading figure of pediatric cardiac surgery in Australia, and in 2016 was appointed as professor of Department of Pediatrics at the University of Melbourne. Now he's moving to Children's Hospital and will work together with our Gil Bernoskis. It's my big pleasure to introduce you, and thanks again. And he will talk about truncus arteriosus. Thank you and welcome.
Thank you very much. So, as you mentioned, I'm a little bit in between two seats. I'm living my last days in Melbourne, and I'm soon going to be in the Children's National. So I didn't know what logo to put on my talk, so I didn't put any logo at all. These are my disclosure. And the main thing I want to say is that a lot of what I'm going to present to you has been built up by my very good friend and colleague, Igor Konstantinov, who's done a remarkable work. When I talk to truncus to fellow, I relate a little bit what I learned in my early surgical training with de Laval. At the end of the day, a truncus, it's a VSD closure and an RV to PA condy. So what's the fuss about it? Well, probably we should be respectful of an operation that still carries 15% mortality, even in very good hands. And let's see why we have such a mortality. Let's first go through anatomy and classification. So persistent truncus arteriosus, common arterial trunk, whatever you want to call it, is coming from a defect in the migration of neural cell crest into the native outflow tract. And as a result, there's no division of the primitive outflow tract. And so the resulting lesion is a single artery with a single semilunar valve, which can be bicuspid, tricuspid, overriding an outlet VSD. There are other associated cardiovascular anomalies, very often a right aortic arch. 12% of the patients have an interrupted aortic arch, most of the time type B. Adductus is almost never there unless there is an interrupted aortic arch. Quite a few of these patients we will see have truncal valve regurgitation. Exceptionally, stenosis is also described. And the position and course of the coronary anomalies of the coronaries can be anomalous in 15, 20%. And actually, I'll make the point that we don't know exactly. If we look at these anomalies, Igor Konstantinov described them in a series of Melbourne, and these are the kind of different position of the coronaries that you can encounter, and likely the anomalies, the restrictions, the slit-like appearance of the coronary ostia is vastly underrepresented. There's clearly an association with genetic lesions, mainly 22q11 deletions, but there are also other chromosomal disorders, deletion, single gene disorders that are associated with the conditions. Classification, the classical one that I learned was the one from Collett and Edwards. The 4 did not exist, we agree with that. Depending on where the pulmonary artery arrived, there was very importantly the classification of Van Praag, but it was thereafter criticized. People say that the type B did not exist. And there was some discussion a few years ago about this classification. And the Collett classification was criticized because something like this could be classified as well as the type 1 and the type 3. And so these are the dominant classification now for the STS and now even the European Society. You have a dominant pulmonary component or a dominant aortic component. At the end of the day, only 2 lesions to remember. That's quite easy. Let's look at the symptoms. They can have cyanosis, but most of the time, heart failure is dominant. The diagnosis is easily made by a transthoracic echocardiogram. So when should we operate these patients? Well, it's easy for the patients with interrupted or aplastic arch to need an operation quickly. And the same is for patients with significant truncal valve regurgitation. It's always easy to distinguish the patients who have heart failure that is no longer controlled by medical therapy, but it's a little bit more difficult in case of asymptomatic patients. And I think that when I talk to my colleagues around the world, the majority of them would like to do the operation around 7 to 14 days. I have to say that in Australia, our practice has been different. When I arrived there, I was surprised to hear that we were doing there initially, and not in every patient, but in a lot of them, the operation at 6 weeks of age. And I was told by Christian Brizard, my head of department at the time, that if you operate them at the time, they're really rock solid. And I have to say that that is quite right. There are also mention of temporary solution, and I have to say that I cringe when I hear about bilateral PA banding, which was tried in the early 70s and early 80s, but gave disastrous results. And I've heard about people trying a repair without closure of the VSDs, but I cannot believe that these patients are stable hemodynamically afterwards. And I think that these procedures should be avoided. Let's go through some technical details. So I usually detach the pulmonary trunk from the aorta by doing actually a little triangular incision here, which is closed directly, not vertically as in his drawing, but horizontally. And then I proceed with the ventriculotomy. What I explain my fellow usually is that there's 2 things to avoid when you do the ventriculotomy. Keep going forward. Is you have to take care of the LAD, and even when you start your incision, it may be far away, but as you retract on this incision, the tear is easily made that goes close to the LAD, and then closure, putting your RV to PA conduit can be quite challenging. And also, I mentioned to them, the truncal valve is always closer to your opening than what you can believe. And then you establish the continuity, and classically, we've used Contegra conduit or homograft, depending on the part of the world you are. We don't have much access to homograft, so we've used a lot of Contegra conduit. Or it has become popular now to use Gore-Tex conduit, or to proceed with valveless repair. The thing that the people, I think, do not realize very well, and it's a personal point of view, but I think that when you suture a homograft to these PA are not enormous, they're not gigantic, and you usually suture a circumferential, a cylindrical structure, which diameter is much bigger than the diameter of the PA. And it's very easy then to obtain a flattening of the origin of the PA. And that's the reason why I think we see so many of these origin pulmonary artery stenosis in these truncus. Interestingly, there was a paper a few years ago in JTCVS showing that the most important predictor of major adverse cardiac events was actually having a bigger size of homograft in the repair, which I think is because of that phenomenon. It has become increasingly popular in the last few years now to do a valveless repair, and you can, not in everybody, but sometimes you can quite easily pull the opening of the pulmonary artery bifurcation onto the ventriculotomy, sometimes by using an artifice like this one, or sometimes directly. And I've heard Olivier Reski, who will talk soon, of using the atrial appendage as a bridge of tissue between the pulmonary artery and the ventriculotomy. And the results are surprisingly good with this valveless repair. Osemi Honjo from Toronto, at the time he was working with Sunji Sano, published these small studies, but half of the patients did not need a reoperation almost 10 years. And that's what we're seeing also in Melbourne. That's why we've been using either these valveless conduits with putting an anterior patch on, or this little Gore-Tex conduit. We use a 8 or 10 millimeter, and it lasts many years. There are several techniques to repair interrupted aortic arch with truncus. In Melbourne, we've been advocating as a repair of the interrupted arch what we call the end-to-side repair, which is a very good technique as such, but not in the case of truncus. We have demonstrated that one of the main predictors of having a left main bronchus obstruction with an end-to-side repair is doing it in a case of truncus. Generally speaking, when you have a large root and you do an end-to-side repair, you reduce the size under the concavity of the arch, and that's the factors that will lead to bronchus obstruction. And so my favorite technique is to do a patch repair in case of interrupted aortic arch and a truncus repair. And my favorite material in the last few years has been the 3D cardiocell patch. Let's have a look at the impact of truncal valve surgery on the outcomes of truncus repair. So Igor led this work again in Melbourne, and we have 180 patients historically. 21 of them had a concomitant truncal valve surgery in this first manuscript, and the mortality of these 21 patients was 19%, even higher when we were doing it for neonates. 2/3 of these patients needed a reoperation within 10 years. I think the main finding of this paper was to find out that if you look at the patients in green here who had a concomitant truncal valve surgery, the outcome actually was not by far different than the patients who had in orange here mild truncal valve insufficiency that did not require surgery, and not far different from the patients who did not have any insufficiency. But if the truncal valve was moderately regurgitant or more, their mortality was really significant. Half of them would die very rapidly. And so you cannot tolerate moderate truncal valve regurgitation. You have to do something about it. He then looked at the outcomes of patients who had a quadricuspid truncal valve, a very common feature in truncuses. We had 56 patients, about a quarter of the patients in our theater series. It was done a bit later than the previous paper. Tricuspid valve insufficiency was presented in 39 patients. 14 had concomitant valve surgery with an early mortality of 14% versus 9.5% if they didn't have it. And interestingly, you see, it's a more recent paper, but it shows you that we kind of master that surgery for quadricuspid truncal valve because it was less than in the overall population of patients who had this truncal valve surgery. Tricuspid valve insufficiency further progressed in 7 patients, which tell us that about 1/3 of the patients, total of the patients who had a quadricuspid valve, ultimately required valve surgery at some stage. And interestingly, the freedom from reoperation in this group was much better, which shows again that I think we did master this surgery in Melbourne for this quadricuspid valve, to the point that the survival was actually identical if the patients had mild or less tricuspid valve insufficiency, or if they had moderate or more, and whether they had concomitant valve surgery or not. So what kind of surgery we were doing? So you can operate these patients by keeping the valve tricuspid, and you can work on the wall, on the cusp themselves, or doing subcommissural annuloplasty, as you see here. Or you can keep the valve, make the valve tricuspid by either putting 2 of the leaflets together, or, and that has been our favorite technique in the last few years, by resecting the entire sinus and one cusp. You take the smaller of the one, and you have to prolong the incision even lower than that onto the muscle through the annulus and close it. And that has been a very successful technique. So when we compared our technique of tricuspidization versus the technique that did leave the valve quadricuspid or even replace the valve, well, our results were by far superior in terms of reoperation if we did make the valve tricuspid, while all of those who had another type of repair needed a reoperation. In one of these recent patients, we had an intramural coronary artery, and that's the case that we described. There's also a video on the web on that patient. But that attracted our attention about intramural coronary artery. We had 7 of these patients. That paper will be published soon. 4 of these patients needed an unroofing concomitant to the repair. 1 of them did not do well, had to be reoperated. Ultimately, we need to reimplant this coronary, and the patient was discharged but had a sudden death 6 months later. Another patient who was left with a roofed coronary had another cardiac arrest on postoperative day 1, and only 2 patients who had not that issues addressed were alive at 18 and 20 years. So it tells you that a lot of these patients may get into trouble, and it is worth to unroof this intramural tract. What are the outcomes? Well, if you look at large data sets, the data set from the European Congenital Heart Surgeons Association shows you that the mortality was 15%. A more recent survey from the STS data from 14 to 17 shows a mortality of 9.5%. And clearly, if you look at overall series, and that's just one of the example of a smaller series, the mortality has evolved before 2000 and after. In that paper, we had a mortality of 46% before 96 and 4% thereafter. What are the risk factors for mortality? I think that people keep always the same thing in mind, and that paper has been very influential in that. Large number of patients from the congenital heart surgery database, 572 patients. If the patient had an isolated truncus repair, the mortality was 10%. If you add to that repair an interrupted aortic arch repair, the mortality jumped to 24%. You added up a truncal valve repair, the mortality was 30%. And if you added both an arch repair and a truncal valve repair, then the mortality jumped to 60%. And so that's what the people have in mind, and undoubtedly you have two, is interrupted aortic arch and truncal valve surgery as a risk factor. Let's have a look at what we had in Melbourne. In our series, we had 20 early and 19 late deaths. Interestingly, most of these late deaths occur during the first year of life. The mortality, like everywhere else in the world, improved from before 2000 in 18% to 11%. Our papers, I think, is the only one that encapsulates the very long-term survival, 74%. That tells you two things. First of all, once they survive the first year of life, the survival is not bad, but still, it's a very serious condition. I mean, that is not far from the number I quote for patients born with hypoplastic left heart syndrome. The risk factor for early mortality was ECMO, having a weight of less than 2.5 kilo, previous operation. I think that these were the palliative surgery I talked about, and having a coronary anomaly. And you will see the conspicuous absence of interrupted aortic arch repair and truncal valve surgery. And in another paper encapsulating the whole Australian experience, the early mortality was 13%, the 20-year survival was similar, 77%. The risk factor for early mortality was neonatal surgery and low operative weight, and the risk factors for late mortality were coronary anomalies. And the 20 years freedom from operation, as you can expect, at least in this historical series, is about 2%. But I'd like you to pay attention about these factors, neonatal surgery being a risk factor for mortality. And I know that for the majority of the people, it is no longer fashionable to delay an operation in the truncus. And that's what happened in Australia as well. We decreased the age of operation progressively, but in the early era and in the late era, the mortality for newborn patients was still higher. And yes, there were a lot of bias, but that was a clear fact. And I don't say that you have to wait to operate your patient, but I think it is worth thinking about. And the importance of coronary anomalies, I believe, have been underestimated. It is an important risk factor early, but even late in these patients. In conclusion, I believe that truncus is still a serious condition, but progress has been made even in recent years, unlike a lot of conditions in congenital heart disease. Early mortality is still hovering around 10%, and a quarter of the patients die before the age of 20. It may be better today, but we do not have these statistics yet. Progresses are likely related to a better understanding of the indications. We don't do any stupid palliative operation anymore. We know that we have to operate the patients when they have signs of heart failure. And when they do have moderate or more truncal valve regurgitation, that necessitates an intervention too. We have a better technique to repair the interrupted aortic arch. We've understood the benefits of tricuspidization of quadricuspid valve. And I do believe that valveless repair of the continuity between the RV and the PA brings a benefit to the patients. And clearly, we had, over the course of these historical times, better postoperative management. We know how to put PA lines in this patient after the operation and how to use nitric oxide. And I suspect, and I may be completely wrong in that, but I suspect that to progress further, we need to better define coronary anomalies in these patients. I mean, before 3 years ago, I never looked at the coronaries of this patient. I was just doing the operation. And I think that if you pay attention, often you find these anomalies restricted coronary orifice, anomaly of the position. And I don't know exactly what needs to be done when in which patients, but I think that if we're progressing in this understanding, we may further improve the survival of these patients. Thank you very much. And that's Igor and myself for showing in a dress up for Heart Kids or Parents Association. Thank you.
Amazing. Thank you very much. And it's very nice to see that in our field we still can develop things and we can improve. This is very nice. Okay, now guys, we are going to have a short break where we are going to be able to discuss with all of you some of the things that we saw so far. But we are going to continue in 15 minutes with a lot of more interesting talks. So hope all of you can stay with us. So we are going to start with a poll. We want to know who you are. So please tell us what is your job? How do you describe yourself? Let's see this time. Usually we have the biggest amount of pediatric cardiologists and PICU, CICU physicians. Let's see, as is a surgical talk, if you're going to have something different.
Can be some surprise today, huh?
Yeah, let's see.
I hope will be, because Gil, we fight, we say about there is a few surgeons every time to the...
Exactly.
But this time we will win. I'm sure we are at least 50-50. So here we go. Grace, sorry, but I don't manipulate the poll.
Okay. You have a special command on this poll thing, but it's okay. But this is nice. We have 30% of cardiac surgeons. Is a very nice audience. Thank you very much, guys, for being with us.
And
the next one.
Yes. Where they live.
Where are you from? Where do you live, actually?
During before we start the meeting, we discuss about which country is more now is moving with the people, and I told that we are very happy because we have a real balance between the different states. Of course, the time is very important, and we think that we are moving with Asia, Africa, and is confirmed today. So we must be. It's very difficult with Australia, probably because of the time. For them, it's night, but we will see in the future. Yes.
So very nice. Well, we have a very good audience from the US. Thank you, guys. This hasn't been true until now. But it's a good balance. Thank you very much. So now we have some questions that we are going to make to you about the talks that we had so far. So we are going to start with the first one. If the speaker is able to read their question and explain to the audience, and then we can vote.
Jim, can you read the question for the people?
Yes, I can. For patients undergoing repair of tetralogy of Fallot with atrioventricular septal defect, compared to palliation and staged repair, primary repair results in improved long-term survival, decreased risk of reoperation on the left atrioventricular valve, lower risk of reoperation directed to the right ventricular outflow tract, or increased risk of reoperation on the right atrioventricular valve.
Big question.
And we are going to have more talks about tetralogy of Fallot in different situations now after the break. I hope you all can stay.
Jim, can I ask you what is your, you have a standard for you, favorite strategy for procedure, or again, you try to adapt according to the different anatomy?
Yeah, if the patient, I sort of dichotomize based on the outlet VSD and how the outlet extension of the VSD and how easily I can access that. And if I think that's going to be a challenge, then I am more likely to go with a one patch approach. But I've used all of them, both of the strategies, and I think you can use a 2-patch repair. That's my typical strategy for a conventional AV canal. But accessing that outflow portion will often require an approach through a ventriculotomy. I've not tried the approach that was written up by Eve and colleagues in Melbourne. That may be also a reasonable strategy.
Okay, here you have the results of the poll.
Well, it was lower risk of reoperation directed to the right ventricular outflow tract. That was the right answer, the C, or the third one.
Okay. So people prefer to say that improve long-term survival.
Yes, no, that wasn't different.
Yes.
There was a trend, but it wasn't. Didn't reach significance. That's the paper from Novosibirsk, which is a meta-analysis of some series in which they could answer that question.
Now we have the poll from Eve. Eve, can you read the poll?
So, which one of the following statement is true? Even mild truncal valve surgery should prompt surgery of the valve at the time of the repair. Moderate or more regurgitation of the truncal valve before repair should prompt a repair of the valve. Patients with regurgitant truncal valve should have a valve replacement as soon as the size of the root allows it to avoid the risk of multiple reoperations.
So again, if you, in your patient, if you prefer doesn't use conduit with valve, or you really use for all patient conduit valveless procedure?
So for all the patients, I would just gently look at how far the pulmonary artery bifurcation, and so I dissect is coming to the ventriculotomy. I always dissect quite far in the hilum, the same way than for arterial switch, so that you have mobilities of the PA, and I don't struggle. I mean, if it's too much of a pull, then we put a Gore-Tex conduit, and it's amazing. I mean, we see, the patients lasting for 8 and 10 years with a 10 millimeter conduit, and that fits much better, we believe, to the pulmonary arteries. We have much less stenosis, pulmonary artery origin stenosis with that. It just fits better than these big, long homograft or Contegra conduit. They're too high as well.
Thank you. I'm sure Olivier will be happy with the French school of the REV operation. So here you have the results. Wait.
We can see.
Yes, sorry.
Yeah, that is quite obvious, and I think that it's amazing to see that repair of this truncal valve can last for longer than the people can suspect, especially if it's the right operation for quadricuspid valves.
Thank you. So I will ask Professor Yacoub if he can open the microphone. We have a few questions for you, or if you want to say something. We can see you, but we cannot hear you.
Sasha, can you unmute him?
Yes.
Can you hear me now?
Yes, there is a few questions for you. And of course, if you want to say some comments about AV canal plus tetralogy or truncus, you are most welcome. So on the same...
Yeah, I do have, but we have a new operation for truncus, which are thinking about publishing very soon, and it depends on the use of autologous tissue, mainly arterial, and preserving the bifurcation of the pulmonary artery. We think is fundamental. But that's all what I'm going to say now. I would love to listen to questions, please.
Okay. There is a question about atrial switch, if there is a sort of any age limit. to use this type of technique in adult also with natural survival with transposition?
Yeah, that's a very good question indeed. Obviously, the sooner the better, but we have been impressed in the absence of a large VSD, which produces severe pulmonary hypertension. Even in these patients, we have found regression of pulmonary hypertension. Sometimes we try and create a ventricular septal defect, but in patients with intact interventricular septum, it is remarkable that sometimes we have had in our SWAN patients presenting at the age of 26 with intact interventricular septum with a hemoglobin of 23 grams, going to university with a saturation of like 50%. And we operated on these patients. Some of them had a degree of pulmonary hypertension. All of them, I mean, the small numbers are small, sailed through the operation, and remarkably, pulmonary hypertension tended to regress in some of them. So, in answer to your question in a long-winded way, there is no limit, particularly if the ventricular septum is intact. The operation is very, very safe. No operative mortality, even if there is a VSD or pulmonary hypertension or comorbidity. Obviously, we want to apply it as early as possible, but you're dealing with a neglected population, I'm afraid. Have I answered the question?
Yes, very well. There is another comment, of course, it's more surgical. If you consider sending or mustard same operation or similar, your
Excellent operation. Excellent question. Thank you. We actually feel that the mustard operation is superior. Why? Because with this modification, we conserve the muscular tissue of the atrium. And as you saw from the technique, we have a very small atriotomy situated inferiorly and posteriorly. We feel that contrary to popular belief, the mustard operation preserves muscle tissue and bands, which we can work with in trying to restore what I have shown you, the contractile function of the atrium. So, in answer to the question, definitely the mustard is preferred to the Senning on this occasion.
Thank you. There is one last question. If the coronary anomalies is still an indication to do a mustard operation also in neonates? In Europe?
Yes, absolutely, because if the patients have survived or do not need direct operation on the aortic root, or we have a lot of experience with anomalous coronaries, but that's not the point here. But the one big advantage of the modified mustard is that you do not touch the aortic root, which we think has sophisticated function. Coronary anatomy or anomalies with which require operation in their own right are very rare and should be watched. But preservation of the aortic root in the mustard operation could be a big advantage, as I indicated in my talk.
Thank you very much. I'm sure you will. We will stress you in the near future again for other appointment. And thanks again. Now we will contact you soon. Thanks, Professor. It was a real privilege for us, and congratulations again for the Ashwan Art Center, which is an example for all over the world. And now we move with Grace to the second part, and thank you again.
Thank you.
And okay, so let's start our second part of this webinar. Sorry, we are going to restart the second part of this webinar. And I would like to ask all the speakers if you could please try to answer the questions that are on the Q&A box. We have already a lot of questions for all of you there, and this makes this discussion even better. So now we are going to talk about Ozaki procedure with Dr. Ozaki. He is a professor and chairman of the Department of Cardiovascular Surgery in Toho University, Ohashi Medical Center in Tokyo, Japan. Thank you very much for joining us. I know it's late for you, but we really appreciate the participation. Thank you, Dr. Ozaki.
Thank you very much for giving me the opportunity, my procedures. So, I will start.
Yes, thank you. It's perfect.
Yeah. We have previously reported the short-term result of my procedure. 404 case in 2014, 850 case in 2018. Now we have evaluated the midterm result with the longest follow-up of 12 years in 1,100 cases. This slide shows a brief overview of my procedures. First, harvest the autologous pericardium, and then treat the pericardium 0.6% glutaraldehyde for 10 minutes. And then excise the valve. We measure distance between the commissure using a discharging apparatus. And then trim the pericardium using the template. After solving, procedure is completed. I'd like to show you the rationale of my procedures. In general, native cusp contact point is slightly lower compared to the horizontal plane made by top of the commissure. Therefore, when cusp is closed, direction of the stress is always downward. It means commissure has a stress. On the other hand, from Ozaki aortic valve, the contact point of new pericardial cusp is raised up to the same plane of commissure. It means direction of stress is horizontal. It means we can minimize the stress on the commissure. This slide shows the management of the pericardium. Generally speaking, pericardium becomes thicker as it nears the diagonal. On the other hand, it becomes thinner as it nears the aortic root. Larger cups tend to have shear stress, and opening-closing move gets so smooth regardless of their stiffness. Therefore, we always cut off the larger cusp from the diagonal side, smaller one from the aortic side. Which direction of pericardium is suitable for every side? A comparison of platelet count between smooth surface facing to the LV side and rough surface facing to the LV side shows a big difference. Having rough surface facing to the LV side, platelet count doesn't recover even in the discharge. This is due to platelet damage caused by friction and collision with the rough surface. Now I'd like to show you my procedure, especially basic technique.
After visualizing the lesion by pulling the retractors, remove surrounding calcification as completely as possible using CUSA. Measure the distances between the commissures using sizers. These sizers evaluate circumferential length between the commissures at the level slightly below the commissure, not the length of each annulus. First, attach one tip of a sizer to a commissure from below. Gently rotate the sizer until the other tip reaches the other commissure, and check if the size fits the distance between the commissures. Repeat this until the appropriate size is measured. If the size falls between two sizes, use the larger one. Put a mark on the midpoint of each annulus. This marking will be the starting point when suturing. The order of sizing should be LCC, RCC, NCC.
27 is adequate size, and mark the midpoint. 29 is too big, so 27 is adequate size. And mark the midpoint.
Write down the measured size on the attached sterile paper. Write the number of suture dots to mark on the annulus. You can refer to the quick reference table. Place dots where needle pass through the tissue with a big bite. These dots should be marked size 11 to 17 is 6 millimeters below the commissure. Size 19 to 37 is 8 millimeters below the commissure. Larger cusps should be made from the thicker diaphragm side of the pericardium. Draw the cusps and mark the dots for suturing according to the corresponding windows on the template with a surgical marker. Latest version of the template introduced dots for creating commissures for easier suturing. Previously, these dots were marked only by eyeballing. Cusps are trimmed with scissors along the outside edge of the lines. Straight scissors should be used for the free edge of the cusps. Curved scissors should be used for the remaining edge. Mark suture dots on the annulus. This image shows the number of suture dots between the big bite dots and the midpoint. The number of dots is the number entered using a simplified chart when measuring cusp size. Mark the dots evenly on the annulus between big bile and midpoint. The number of dots depends on the size of the cusp as follows. 4 dots for size 11 to 23, 5 dots for size 25 to 29, 6 dots for size 31 to 37. If the suture dots are difficult to write, stop marking and sew the specified number of dots evenly between big bite dots and midpoint. Suturing should be performed in the order demonstrated above. RCC is the most difficult part, therefore, RCC is the first commissure, followed by LCC, and then NCC is the last. Suture the LCC side of RCC. Cusps are sutured using 4 to 0 Prolene TF needle 13 millimeters 90 centimeters. Smooth the surface of the cusp faces left ventricular side. This means that dots and lines face left ventricular side. First, suture runs from the midpoint of a cusp to the midpoint of corresponding annulus. And then the cusp is dropped into left ventricle. The suture is tied with 3 knots. The needle should pass exactly on the corresponding dots on the pericardium and the annulus. For the cusp, the needle goes from up to down, and for the annulus, it goes from down to up. The cusp is pushed down on the left ventricular side at the same time to pull a thread so that the cusp is sutured in a subannular manner, not in a supraannular manner, to get a better roundish bulge. When dots marked on the annulus are blurred, you imagine that dots are evenly located between big bite and midpoint. And continue with suturing. The big bite has to be made at the second bite to the last to increase the strength of suturing of the commissure. At the site of big bite, the needle should be manipulated horizontally and hold more tissue than regular bites. Beginning from the midpoint, the sutured zone of the cusp is attached below the annulus before big bite. However, at level of big bite and aft, the cusp is located above the annulus. After the big bite, the needle is straightened using a needle holder. Since the curve of the needle of 4 to 0 TF suture is too strong to accurately pass through the aortic wall, it is necessary to straighten the needle to pass perpendicularly through the aortic wall, which offers a better degree of control. Then carefully penetrate the aortic wall 5 millimeters above the point of big bite, which corresponds to the distance between the dot of big bite and the last dot on the cusp. Previously, the penetrating point was 2 millimeters below the top of commissure, but this has been modified as described to prevent unnecessary wrinkling of the redundant cusp. Create a commissure between RCC and LCC. A 4 to 0 Prolene RB1 17 millimeters 90 centimeters is used to make the commissure. A needle should pass 1. A pair of dots located above the ones for big bite, and 2. A pair of dots at the tip of the cusp. Then carefully pass through the aortic wall so that the wing extension can attach the aortic nicely. After the suture penetrates the aorta, there are 4 sutures outside of the aortic wall. A 5 millimeters by 10 millimeters PTFE pledget is used. 4 sutures should pass through the pledget according to the location of each suture where it comes out of the aortic wall. Basically, the 2 higher threads are wider than the other 2 lower threads. Before tying knots, make sure that 1. The cusp at the area of the commissure is oriented inward, and 2. The wing extensions are faced neatly against the aortic wall. Tie the upper pair of sutures first, then tie the lower pair of sutures. Each pair of sutures are tied with 8 knots. Before closing the aorta, make sure that 1. The 3 cusps form the typical windmill shape. 2. The 3 commissures and the contact point of those commissures are on the same plane. 3. An optimal and large coaptation zone is formed.
We updated my procedure 5 times now. First, we changed the site of the treated pericardium since January 2008 because of the platelet count. Second is the introduction 5 millimeter width with extension since January 2011. I would like to stabilize the commissure site. And third is the complete tricapitation with 3 equal sized cusps since November 2012. In the beginning, I would like to use native cusp attachment line and raffle as much as possible because of their increased tolerance for stress. However, this configuration results in a major discrepancy of cusp size. Due to this, the motion of the cusp is different. It means different sides of the cusp make turbulence flow. Turbulence flow make microembolism. Microembolism make infective endocarditis. So therefore, we decide to change from the incomplete tricapitation to complete tricapitation. We make a new commissure and then we divided the equal cusp. After introduction of complete tricapitation, we can decrease the ratio of the infective endocarditis. Fourth update is the introduction of DOT for easy suturing since December 2013. And we also now we have a new sizer set. There is 3 features. One is the great reproducibility of distance measurement between the commissure because of the new sizer. And second is cup size that allows for easy opening and closing. Third is the safer pericardium fixations. And since April 2007, we have already operated more than 1,200 cases in my institution. From April 2007 to March 2019, we operated on 1,100 cases. Mean age is around 68 years old, almost the aortic stenosis patient. Tricuspid valve is 71%, bicuspid valve is 25%. We also the anaortic ectasis patient. And the mean surgical hernia diameter is 21 millimeter. Japanese people use relatively small. And this shows the age distribution. Patient is mainly in the 60 to 80, but we also have many young patients. Isolated case 611 case, and we also have many concomitant procedures. Mean aortic clock clamping time is 106 minutes. This is a little bit longer compared to the standard aortic valve replacement, but I think it's acceptable. And among the 1,100 cases, we had 24 redo cases. One is tear of the cusp, one is the tear of the thread. 22 patients had infective endocarditis, but the ratio of is 0.38% patient per year. Still very small because if we have infective endocarditis of arterial valve, ratio is 0.8% to 1%. This shows the pressure gradient. Pressure gradient always lower lower than the 20 millimeter mercury. And the freedom from recurrence of moderate AR is 91.4%. Overall survival is 84.6%. Freedom from reoperation is 95.8%. See very good result. And the drug shows the result. Patient under 50 years old. Among the 850 patients, we had 86 patients. Mean age is 35 years old. And close some time and almost same. And we don't have in hospital deaths. And generally, we give aspirin for 6 months. But it depends on the concomitant procedure. We had 4 patients giving the warfarin. And unfortunately, we had 1 redo patient because of the infective endocarditis. And the pressure gradient is always lower than the 20 millimeter mercury. And the freedom from recurrence of moderate AR is 87.2%. Overall survival is 98.8%. Freedom from reoperation is 97.1%. We divided the 3 groups, more than 70, more than 50. And of course, young patient is superior of the overall survival. But there is no significant recurrence between the among the 3 groups about the freedom from the operations. I'd like to show you the one case. This is the longest follow-up of children. Patient is 40 years old. He had a unicast valve and moderate regurgitation as well, and moderate stenosis. And this is a short operation video. Normal combustion is here between the left and non. Rough is here between the left and right, right and non. Left is 23, mark the midpoint. Right is 23. Non is 27. Rough is always lower than the normal combustion, so when we reconstruct the cusp, we adjust the height of the combustion. So 3 combustion and contact point is always on the same planes. This is echocardiography 1 month after operation. Movement of cusp is very good, no regurgitations. Peak pressure gradient just 8 millimeter mercury. And 10 years later, cusp movement of the cusp is still very good. We don't see any calcification on the cusp, no regurgitations. Peak pressure gradient just 10 millimeter mercury. So indications, technically, any aortic valve disease can be treated by Ozaki. So in my institution, all of the aortic valve disease, we do the Ozaki. And good indication is a patient with narrow annulus, female patient with childbearing age, younger patient who cannot or don't want to take anticoagulation. Infective endocarditis is a very good candidate. Any patient indicate for aortic valve repair, patient who indicate for loss procedures, patient who do not want to prosthesis. Conclusions, midterm result of my procedures were excellent. And also, I'd like to announce the new sizer set for the children, especially for the bypass valve, are coming soon. Thank you for your attention.
Thank you, Shigeyuki. As you know, your technique is fascinating the congenital heart world because we have very few strategy and device and valve for our children. And I'm sure, again, your technique has already found a location in the congenital heart patient, and the fact that you are informing us that the sizing for children is coming soon. It make a very interesting tool for congenital heart surgeon. Of course, we can spend one day on about the technique and the results. My personal compliments. But now we move and excuse with Dr. Galletti, Lorenzo Galletti, who is the chairman of pediatric cardiac surgery and mainly Bambino Gesù in hospital. That is one of the biggest program in Italy. And I will. It's my real pleasure to introduce him. That is both friends and very appreciate colleague. And he will talk about Tausi being heart. And I know that if he's there, Lorenzo, please.
Hi. Many thanks, Sasha, for the invitation. I would say that this kind of proceeding, congenital heart surgery education, is a true way, is a right way, because we are allowing a true globalization of congenital heart surgery. This was one of the Lucio Parenzan dream, to globalize our specialties. I think we are in the right way of to allow people to have contact, change concept with more experienced surgeon. Anyway, we are talking about something that is a very complicated malformation, rare malformation, that belongs, as you want to see, to the group of transposition of DORV. We are speaking about a malformation in which there is a bilateral conus on the vessel. I'm influenced by my French training for that. We speak about double outlet right ventricle for us when the two vessels are almost 200% on the right ventricle. That means that there is a significant amount of the overriding of the pulmonary trunk over the ventricular septal defect. Okay, the true ventricular septal defect is not this one. This one is what we close during the procedure, but the true ventricular.
Your screen, Dr. Galletti. We can't see your screen. Sorry. We can't see your screen.
Now you can hear.
No, we can hear you, but we can't see your screen. Now you're muted. You can unmute. You need to do the perfect. Now you have to unmute. You are muted. Unmute again. Okay, now we can hear you and we can see your screen, but we can see your presentation.
Okay, sorry about that. I forgot to put the video. I was saying that we are talking about a complex malformation in which there is bilateral conus over the great vessel. The pulmonary trunk has a significant amount of overriding over the ventricular septal defect. The true ventricular septal defect, that is a malalignment subpulmonary ventricular septal defect, is this one, is not this one, because in double outlet right ventricle, the VSD is the only way for blood to go out from the right ventricle. The great vessel could be side by side, like in this picture, or in anterior-posterior arrangement. There is a significant amount of patients that have subaortic stenosis and associated aortic arch anomalies, even ductal-dependent aortic arch anomalies. There's a frequent amount of coronary artery anomalies, and sometimes we can have, like in many forms of double outlet right ventricle, abnormal chordal attachment over the crest of the septal, the ventricular, over the crest of the septum, and most likely that regard the tricuspid valve much more than the mitral valve. Now, you have here two specimens of that show what I was saying before. This is a subpulmonary ventricular septal defect, the pulmonary trunk, the conal septum that by definition separates aortic and pulmonary trunk. But more interesting are the echo view. Here you have the left ventricle, the overriding pulmonary trunk over the ventricular septal defect. And here you see the aortic outflow. This form as a subaortic stenosis and as also coarctation. I will show you a little bit later. Now, this is a complex malformation. There is basically two strategies for surgical repair. The first one is the anatomical repair that allow the blood to pass to use the aortic outflow, the native aortic outflow as a outflow from the left ventricle. And then this procedure is obtained by the intracardiac tunnel. And the extra anatomical repair made by arterial switch, in which the outflow of the left ventricle would be across the subpulmonary outlet and the pulmonary trunk. The intraventricular repair has been described by Dr. Kawashima in the septum. Is a complex procedure in which you see here the subpulmonary VSD, the conal septum. You should resect to repair with this technique. You should make a wide resection of the conal septum and then construct a baffle from the left ventricle, the VSD, and the aorta. This procedure is quite complex. It's difficult to allow to perform a truly unobstructed tunnel. But the other things that are not feasible in all patients, because if you look at the subset of patients that could be repaired by intraventricular repair, are normally older patients, are patients that most of the time receive previous palliation, either by pulmonary bending, and the intraventricular repair is feasible maybe exclusively in patient that has side-by-side grid vessel arrangement. No patient with anterior-posterior arrangement could receive the Kawashima operation. There is also a risk of residual development of subaortic gradient because, as you see before, the complexity of the tunnel and the fact that your tunnel should cross a very long distance from the ventricular septal defect and the aortic outflow. So for that, more recently, already more than 30 years ago, repair of Tausig-Bingart has been many groups moved to the tunnel through the native pulmonary artery coupled with the arterial switch. Professor Yakub was one of the first that described this procedure and was mostly popularized by the group of initially by the group of Roger. This procedure is complex, but is feasible in almost all group of Tausig-Bingart. Regardless, the grid vessel position is feasible when vessels are side by side. Is feasible when the vessels are in antero-posterior relationship. Whatever the intracardiac anatomy and the coronary pattern is normally performed in the neonatal or in the first weeks of age after the immediate newborn period. It's a long challenge operation that has to deal with several elements. The first is the VSD closure that is not a true VSD closure, but is a rerouting to the pulmonary artery. Has to deal with coronary anomalies that is particularly frequent in this kind of malformation. You have to deal with the aortopulmonary significant mismatch that isn't even worse when there is aortic arch abnormalities or coarctation. that are quite frequent in this malformation. And you have to deal also with the reconstruction of the right ventricular outflow tract that could be particularly challenging. Being a long and complex operation, the strategy of cardiopulmonary bypass and myocardial protection are paramount important in our center, and even in my previous experience. I used to use moderate hypothermic with bicaval cannulation, cardiopulmonary bypass, using most of the time a selective period of cerebral perfusion to reconstruct the aortic arch, and I use single dose of Del Nido blood cardioplegia. Now, I have to fix all the key points in my mind, all the key points of this repair. The first one is the VSD closure. As I say before, is not a true VSD closure. The true VSD, once again, is this one, but you have to fashion the patch in the way to tunnel the ventricular septal defect to the pulmonary orifice. The defect could be more or less big. Normally, it's a big one that you have not to enlarge in the newborn period, but sometimes, occasionally, you need to enlarge because the VSD is not enough and could cause subaortic stenosis. In my experience, I learned in Paris to do that through the native pulmonary orifice, will be the aortic orifice afterward. You could do a running suture, but depends the upper part of the defect, how far you are from the semilunar valve. Because at the beginning of the experience, we used to put from inside on the annulus of the pulmonary valve a stitch. In the last, afterwards, we moved to what we call the magic stitch, closing the upper part of the VSD with a stitch from outside to avoid or decrease the risk of damage of the neo-aortic valve. I would say that there is also center that close the VSD through the right ventricle, and that is also an option to enlarge successively with a patch the right ventricular outflow tract if is small, like we will see afterwards. The second point is the coronary relocation. First of all, the normal anatomy is in Tau-Sibing heart, the sinus one is the anterior sinus where the right coronary artery coming off, okay? And sinus 2 is the posterior sinus where the come left anterior descending and circumflex artery. But frequent, there is abnormal looping of the coronary artery. And anytime that there is abnormal looping, like a coronary that passes behind the great vessel or in front of a great vessel, there is anytime a risk of damage the course of the coronary artery. When the vessel pass behind the great vessel, the risk is the kinking of the coronary artery because the course is shortened with the relocation. Exactly the opposite when the vessel pass in front of one of the vessel, like in this picture. So in the first case, one of the solutions could be put the coronary anastomosis upper the aortic suture line in the way to make longer the course of the coronary artery and compensate the potential kinking. Also, the trapdoor could help in compensate the extra course of the coronary. In the second case, once again, the use of trap could be useful, but you have especially to move the coronary artery as long as possible to allow a decrease of the tension of all the course of the coronary artery. You see here, in this case, this is anteroposterior location, but you see the course of the coronary eye in front of the vessel. In this case, is the right coronary artery, and you should mobilize as much as possible over the course of the vessel. And then relocate with I normally use a trapdoor technique, very small trapdoor technique. And putting the coronary with the atoproline in the appropriate neosinus. The other element is the aortic arch. The other element is the aortic arch. As you see here, this is a patient that has almost virtually interruption of the aortic isthmus. This is the anonymous the brachiocephalic trunk, the left carotid, the subclavian artery. There is also interruption of the isthmus. This patient has been palliated before with a bilateral bending and keep on prostaglandin because has a very bad presentation with shock in a premature baby. So we allowed around 1 month before performing the repair. And already in 1997 in Paris, we published our technique to repair conotruncal anomalies with aortic abscess obstruction, and since the beginning of experience, we look the homograph patch as the ideal repair, especially in this condition. Why? Because you have also the opportunity not only to enlarge the aortic arch, but also to enlarge the ascending aorta and compensate the mismatch between the pulmonary artery that will be the aortic outflow and the aortic ascending aorta. So we saw also in our experience that the single stage management had better results than two-stage management with a significant decrease in mortality and also in recurrent aortic arch obstruction. The final point is the right ventricle outflow tract reconstruction. Why there is this problem? First of all, because the discrepancy of the vessel, the fact that as we saw in the presence of aortic arch anomalies, the aortic annulus that will be the pulmonary annulus is smaller, and there is the presence of subaortic obstruction by septal malalignment band or anomalous muscle band. Anytime that I do a switch for this procedure, I perform resection of the parietal band, but sometimes it's not necessary, it's not enough, because you have also to patch the outflow. One of the points is also if perform or not the Lecomte maneuver in this malformation. I'm not so strict in perform or not perform the Lecomte. I would say when there is no risk to compress the anterior coronary button, I perform the Lecomte. But the Lecomte maneuver, in most of the case, you have to move your anastomosis of the neo-pulmonary outflow tract over the right pulmonary artery, closing partially the stump of the pulmonary on the left side and opening on the right side. What are the results of the switch for Tau-CBing? They are quite good, because if you have to think that this is a very complex malformation in the field of biventricular repair, but the mortality is around a little less of 10%, but the mortality is higher in presence of coronary anomalies. These are the results of the group of Marilla Nelong, and you see that the type A and type D, that means circumflex from the right artery, has carry on the same survival probability, but the survival probability decrease in presence of intramural or abnormal looping of the coronary artery. There is a constant risk of reoperation in this disease, not only on the right side, and we saw before the reason, but also on the LVOTO, left ventricle outflow tract, and the aorta. In the series of Paris, 5 patients were reoperated for aortic regurgitation, and that had two main causes. The first one, that most of those patients had a previous pulmonary artery bending, and that is a well-known prognostic factor to develop aortic regurgitation. But the second was also that in some patients we did not recognize at the time the need for VSD enlargement. The risk of later operation is also described by the Melbourne group. This is the reoperation rate. You see, approximate only 70% of patients are free from reoperation in 5 years. That is quite significant, higher amount if you compare to a regular switch. And there is also an increased tendency over the follow-up to develop moderate or more aortic valve regurgitation. So in conclusion, results of biventricular repair for tau Bing anomaly are excellent, with 1 year survival after repair approach exceed 90%. The stage repair has inferior result compared to single stage repair. A group of patients is still a high risk for mortality, especially on the base of coronary artery patents, and reintervention is common, but it's the good news that is in generally low risk reoperation. Thank you very much from our city, and stay healthy to everybody, and I hope to see you somewhere in the world, more or less. Bye.
Grazie mille, Dr. Galetti. Very nice review for us, and your experience as well that you told us. It was very good. Now we're going to move forward for our next speaker. He's going to talk about tetralogy of Fallot with pulmonary atresia and MAPCAS. We are going to have now Dr. Michael Ma. He is assistant professor at the Standard University. Thank you very much for being with us, Michael.
Great, thank you. Let me see if I can share my screen really quickly. Okay, I think it's visible now. Is that accurate?
Yeah.
Okay.
Thank you.
All right, well, good morning, good afternoon, good evening to all of my colleagues from around the world. Thank you for joining us today on this session. To the organizers of the Academy, thank you very much for inviting me out here to give this presentation today. I have no financial disclosures to make about our surgical management of TED-PA MAPCAS. I will say that we are a very busy referral center for this otherwise very rare lesion. So I have tried to gear this talk for this diverse audience, and I apologize if any of the slides I provide are too basic for your education. So I think to start with, MAPCAS, the complexity and management of MAPCAS is really related to the heterogeneous anatomy that we often see with this lesion. So what do I mean by this? I mean that if you take a normal patient with normal pulmonary blood flow, a patient like this will have a main pulmonary artery that will branch into confluent pulmonary branch arteries that then divide into lobar segmental level vessels, and the blood flow that achieves gas exchange passes through all of these vessels. Once we start adding MAPCAS into the system, things become much more complicated. This is a schematic of a patient who has confluent branch pulmonary arteries that supply territories of the left upper and the right lower lobes, but then also has MAPKAs that supply blood flow to the right upper, right middle, and left lower lobes. And when you start seeing many of these patients, you realize that there is an entire spectrum of what these MAPKAs can and will do. There can be a single MAPKA, there can be several MAPKAs. Their course through the central mediastinum can be very varied and often intertwined with the airways and the aerodigestive tract. The reliability of the MAPKAs, the quality of the MAPKAs can change very quickly over time. So you may have MAPKAs that are very generous and provide lots of pulmonary blood flow, and you may have MAPKAs that become very stenotic very quickly. And conversely, if the MAPKAs do not become stenotic very quickly, they can provide too much blood flow for that area of lung. So this schematic here then This schematic here then shows a much more complicated patient with hypoplastic confluent pulmonary arteries that only supply small areas of the bilateral lung fields, and an additional MAPKA, 4 MAPKAs now, that each have important stenoses as they trifurcate and bifurcate into functional lung tissue. So as you can compare this patient schematic from the one prior, the reconstruction for this patient will be much more extensive and much more complicated to achieve a similar result. And this heterogeneity is really what is at the foundation for the complex management algorithm that we have devised here at Stanford. What are our overall goals? The goals are to maximize lung perfusion at the lowest possible perfusion pressure, which will allow us to minimize the amount of afterload on the right heart. And this minimized afterload then will hopefully allow us to have the appropriate sort of sequential pulmonary vascular resistance to allow septation of this heart so that the right ventricle can handle its appropriate afterload. And at our center, because we see MAPKAs quite often, we're seeing more and more referrals for patients with complex intracardiac single ventricle pathologies with MAPKAs. In those situations, obviously, a MAPKA reconstruction will allow us to have the best pulmonary vascular bed for an eventual palliative strategy that achieves Glenn and then Fontan physiology. This is a slide that shows the management algorithm that we have devised here at our center over the last 15 to 20 years. This has been published in many of our manuscripts on this topic. Essentially, I'll focus your attention on this box, elective repair at age 4 to 7 months. So for all comers, when possible, we try to delay repair for these patients until they're slightly older than the neonatal and early infant period. And we do so because the MAPKAs are easier to handle at that older age, and because the airways are more mature, and because a lot of the dissection of these MAPKAs occurs around the airways, they have less airway edema and less airway complications if we're able to delay surgery to the 4 to 7 month mark. The reason we don't operate or try not to operate on these patients much later than the 4 to 7 month mark is because the MAPKAs are not very reliable. And if they develop stenoses over time, those areas of lung tissue distal to the stenosis can be lost. And in other situations, if they do not develop appropriate stenoses, those areas of lung tissue can overcirculate very badly and develop pulmonary vascular obstructive disease in those territories of lung. So we have found the optimal age range to be the 4 to 7 month mark. There are several reasons why we would try to perform surgery on these patients earlier, and I've listed those both in these various boxes in the algorithm diagram, as well as on the right here on the slide. So reasons for neonatal intervention include 2 anatomic reasons and 2 physiologic. The 2 anatomic reasons we would go in and operate on these patients early include patients with isolated ductal dependent flow to one side, meaning they have either a left or a right hemiductus supplying flow to that pulmonary artery with contralateral MAPKAs. For those patients, we will try to perform some sort of stabilizing operation to allow blood flow to continue to that side of the lung without the need for prostaglandin. And the second anatomic reason we would go in early for these patients are for those patients with completely dual supply MAPGAs, meaning the confluent branch pulmonary artery as well as the MAPGA supplies all the same territories of lung. So in that situation, we will try to promote antegrade blood flow through the central confluent pulmonary arteries through the creation of an aortopulmonary window. And then we will bring those patients back usually at about 6 months to see if our central shunting strategy allowed enough growth so that we don't have to use too many of the MAPGAs in the eventual reconstruction. And then obviously all these patients behave like arterial level shunts. So for physiologic reasons, either if that arterial level shunt is inadequate to provide enough pulmonary blood flow or too adequate and provides excessive pulmonary blood flow, in either of those situations, we may be forced to provide a neonatal intervention. Whether or not that is a full repair depends really on the individual anatomy of each patient. So I thought it would be helpful now to go through a quick case example about how we would think about tackling a garden variety patient like this. So a full-term 3.5 kilo, 1-week-old baby presents with DeGeorge and Tet MAPGAs. He is clinically well appearing, has an O2 saturation of 85% without supplemental oxygen. An echocardiogram demonstrates typical tetralogy with a large cone of ventricular VSD and an overriding aorta with plate-like pulmonary atresia. We perform a catheterization, and these are the findings here on the right. As you can see from this diagram, in box A, there is a confluent main pulmonary artery with confluent right and left pulmonary arteries that supply territories to the right upper, right middle lobes, as well as the left upper and left lower lobes. And this is in dual supply to a MAPGA that is coming off the undersurface of the aortic arch that enters into the proximal right pulmonary artery here. This patient has separately 3 additional MAPGAs that we would call single supply. This patient has a MAPGA that provides blood flow from the descending thoracic aorta to territories of the right upper lobe and the right lower lobes, and then 2 additional MAPGAs coming from the proximal descending aorta that give rise to territories of lung in the left upper, left lingular, and left lower lobes. So the correct answer amongst these choices at our center would be elective surgical intervention for this patient at 6 months through unifocalization of both the confluent branch pulmonary arteries as well as the 3 additional single supply MAPGAs here. We would perform a flow study and then attempt intracardiac repair if the neopulmonary tree was adequate to supply a full cardiac output at a low pulmonary artery pressure. I think it's helpful to talk through each of these other answer choices. I think choice A is probably geared towards all of the outpatient cardiologists that would be listening in on this talk, and that is a patient like this with multiple sources of pulmonary blood flow cannot be effectively monitored as an outpatient with echocardiogram alone and assessment of the systemic saturation. The reason for this is that each of these MAPGAs is a different source of blood flow to a different area of lung. So even if a patient like this has a stable echocardiogram on serial follow-up and has a stable saturation, we do not know what is happening to each of these MAPGAs over the course of that first year or 2 of follow-up. We do not know if MAPGAs number 1 and 2 are becoming very stenotic and flow to that area of lung is gone, while MAPGA number 3 is not stenotic and has excessive pulmonary blood flow. The average return pulmonary blood flow that we might be seeing might be 85% for that patient, but that patient might have very unhealthy pulmonary vasculature in one area and no perfusion in another area. So answer choice A is erroneous in our opinion. Choices B, C, and D are all similar. These are all strategies that are aimed at improving antegrade flow through confluent branch pulmonary arteries. And these can all be successful if the confluent branch pulmonary arteries reach the majority of the lung parenchyma. So in a situation like the one presented here, a patient like this would not be served well with a central augmentation strategy, because if we grow only the areas of lung that are fed by the confluent pulmonary arteries, we will be losing perfusion to where the single supply macas are providing flow. So B, C, and D are all strategies that are relevant if the confluent branch pulmonary arteries can supply a large majority of the lung parenchyma in an antegrade fashion. Moving from this to surgical techniques, we will approach this lesion through a median sternotomy. We perform all of the MAPCA dissection prior to going on bypass, prior to systemic heparinization. This is extremely important because we like to dissect these MAPCAs out into at least their first order bifurcations in the lung parenchyma. And as we are pushing lung tissue away and exposing the MAPCA, that lung tissue can be very friable after systemic heparin. And it may be very difficult to control bleeding coming off bypass after the reconstruction. So we do try to dissect these MAPCAs out as far as we think we're going to need to utilize them during the initial phase of the operation before systemic heparin. After this, cannulation strategy includes the ascending aorta, bicable cannulation, and then an LV vent. We initiate bypass and immediately ligate all the MAPCAs to prevent systemic steal, and then we cool these patients to 25 degrees Celsius for the reconstruction. The MAPCA reconstruction can take several hours, and in all situations, we try to prioritize side-to-side anastomoses, native-to-native connections to allow growth and prevent stenoses of the reconstruction. And then we have to be very respectful of how these MAPCAs course into the lung parenchyma. The MAPCAs that try or tend to stay posterior to the airways usually want to stay posterior to the airways, and those that are anterior to the airways like to stay anterior to the airways. We perform a flow study at the end of all this, where we try to index 3 liters per minute per meter squared into the neopulmonary tree. We will measure a mean PA pressure in that circuit, and if that mean PA pressure is less than 25 millimeters of mercury, we will then commence and complete intracardiac septation with a VSD closure and then a conduit that is placed to the newly constructed pulmonary bed. If the flow study fails, we will then shunt these patients with a central shunt from the side of the ascending aorta into the reconstructed pulmonary arteries in an attempt to then further grow these pulmonary arteries for an eventual septation, usually 6 to 12 months down the road after a repeat catheterization. So here are some illustrations that demonstrate our techniques. Again, this is simply the ascending and bicable cannulation for bypass. Here are all the MAPCAs that have been isolated from their systemic supply from the ascending aorta and various head vessels out to their lung bifurcations. And then here are some diagrams that demonstrate the various anastomotic techniques for these different vessels. Of course, techniques A, B, and H are the ones we prefer because these provide longitudinal side-to-side connections that are less likely to stenose over time. Here's a central hilum to hilum PA homograph patch that we utilize at the end of the reconstruction. We do a flow study into this system, and then if it's favorable, we can perform the VSD repair through the right ventriculotomy and then a conduit placement into that circuit as demonstrated here in the box below. So what are the results? Here at our center, we now perform MAPCA surgery about twice a week. Over the last 15 years, we've done about 500 operations for this diagnosis. Using the techniques that we learned from MAPCAs, we have also started to augment distal pulmonary arteries and a lot of other conditions. So routinely now at Stanford, we perform about 4 distal pulmonary artery procedures a week. When it comes to MAPCAs themselves, a recent study that we published showed in all comers for patients that came to our center for their first stage of management, 307 patients. We had 280 patients that achieved complete repair for a complete repair rate, a septation rate of 91.2%. If we look at actuarial survival, these patients tend to do very well over a long period of time. And when we look at the average RV to LV pressure ratios for these patients, we see that in both single stage repairs and those that required palliations up front, that we have RV to LV pressure ratios that are very nice and low, between 36 and 40% on average. So to conclude, this lesion really derives its complexity from the intrinsic heterogeneity in the various sources of pulmonary blood flow. Any comprehensive treatment algorithm for this needs to maximize reconstruction of all sources of pulmonary blood flow, and this treatment strategy must be tailored to each individual patient's anatomy with the ultimate goal of achieving biventricular septation or univentricular palliation for those patients with univentricular hearts. The longitudinal results from our analysis of our series are quite favorable, with 90% of our patients achieving a complete repair at an appropriate RV to LV pressure ratio. So I will conclude here. This is a picture of me operating with my mentor, Dr. Frank Hanley, who is obviously the pioneer of all that you have seen in today's talk. Thank you.
Davide. Sì. Hey, hello, everybody. It's my real pleasure to introduce now Professor Olivier Rasky, Professor of Surgery at the University of Paris-Descartes, Director of Pediatric and Congenital Heart Surgery Program and Department at Necker and Femme Malade Hospital in Paris, France. He is surely the most talented surgeon I have ever worked with, as well as a dear friend. So, Olivier, to you with the talk about tetralogy of Fallot and abnormal coronary arteries.
Thank you, Davide, for this introduction, and thank you for the invitation that you sent me, Sasha, and you. So the aim of this talk is to try to convince people who are still thinking that conduit are the best option to treat tetralogy of Fallot with abnormal coronaries arteries, that there are other options. So you are not unlucky because you had to deal with anomalous coronary artery while you were repairing tetralogy of Fallot, because it's a very frequent.
Sorry, you have to share your screen. You have to share your screen. We don't see your slide. Sorry. Share screen.
Okay. Is that okay?
No.
No, we can see it.
I share my screen, but you can't. Okay. Can you see it now?
Oh, no, nothing. Are you hitting the green button on the bottom of your screen? Of share screen of Zoom?
I did it. And then I'm very sorry for this, but I asked to share my screen.
No, nothing is coming so far.
Okay, can you do it for me?
No. Yes. Did you send me your presentation?
Yeah, I did it.
Yep. Sorry for that, guys. Can you see it?
Yeah, I can see it.
Yes.
Okay. So just tell me to move forward.
Okay. So the aim of this talk is to try to convince people who are still repairing fallow with abnormal coronary arteries that a conduit is not the best option anymore. If you think that, next slide, please. If you think that you are unlucky because you had to face abnormal coronaries, this is not unusual. Because abnormal coronary arteries is about 6% of different fallow. Next slide, please. And about 75% of the anomalous coronary arteries are crossing the right ventricular outflow tract. Next. So mainly the LAD origin from the right coronary in about 50%. Next. But there are other different options, and the right coronary can come from the LAD as well. Or you can get a very large coronary artery from the right with giving a dual LAD system. Next. They are very rare situations, but they can be very risky. For example, you can get an anomalous aortic origin, and you can have an LAD originating from the right sinus and get an intraseptal course. And this is very dangerous because while you are closing the outflow VSD, I mean, you can catch at the upper margin of a VSD this anomalous artery. Some patients very rarely can get an anomalous left coronary artery from the PA, or sometimes you can get coronary arteriovenous fistula that needs to be addressed during fallow repair. Next. So the echo is probably the first exam to make the diagnosis of these abnormal coronaries. The sensibility is about 50 to 85%, but it's completely dependent about the experience of a physician. So, but is it mandatory to make the diagnosis before surgery? I think so, because it allows to plan to have a very experienced surgeon in the operating room. And at the same time, sometimes you can delay the operation when it's possible, because some surgical repair might be very difficult to perform before 2 months. But you have to keep in mind as a surgeon by the fact that the final diagnosis is the responsibility of the surgeon, whatever the different preoperative exam you have done before. Next. Of course, CT scan is now the gold standard method to make the diagnosis of these coronaries. It has a very high sensitivity and specificity, particularly is useful for redo surgery. And what about the place of coronarography now? I don't think it's a routine exam anymore, except for very complex lesions, for neonates, and sometimes when you get coronary ischemia after surgery. Next. So what are the objectives of a repair? First is to preserve the abnormal coronary. Next. Of course, you need to preserve the abnormal coronary, and I would like to point it out the importance of a safety zone. I don't know if it's 1 centimeter, 5 millimeter, few millimeters in neonates, but you have to be very careful while you are doing your infundibulotomy or your ventriculotomy that you can get tears and be very close to the coronaries later. So keep in mind that you have to preserve at any time the coronary, whatever the repair is. Next, the second objective is, of course, to release the right ventricular outflow tract obstruction at the infundibular, valvar, and annular level. And finally, to limit the risk of reoperation. Next. So there are many different surgical repair. Transatrial, transpulmonary repair, main pulmonary artery translocation, coronary mobilization, double barrel technique, coronary translocation, and of course, RV to PA conduit. Next. Is it a real option, a valve conduit to repair a fallow? If you look at the result on the children population about the conduit during the late outcome in terms of reoperation or reintervention, you don't want to use this, especially with a tiny diameter like we have to use when we repair a fallow. Next. And whatever the conduit is, even the best ones as homograph, aortic or pulmonary homograph, the results are not very good. And it's not because you are going to get a reoperation that you won't get a second or a third reoperation. Next. If you have a look now at the long-term result of the RVOT reconstruction of children, I mean, the non-transannular patch is really superior to the total transannular patch, or the transannular patch with monocost, or even better than the pulmonary or the aortic homograft. Next. But there is a big gap between the theory and the reality, because if you look at database from Europe or US, you will see that there is a significant number of tetralogy of fallow without pulmonary atresia that are being repaired with RV to PA conduit, about 3%. And when you know that there is about 5 to 6% of fallow with abnormal coronaries, it means that there is a significant number of patients who will get RV to PA conduit at repair. Next. So my main message is that you can make a surgical repair of a fallow with abnormal coronary artery without the use of a conduit. You can make a main pulmonary artery translocation, a double barrel technique, a coronary mobilization, or even better, in my point of view, a transatrial transpulmonary approach. Next. So the main pulmonary artery translocation, you are going to divide the main PA very close to the annulus. Then you are going to do a novation of the proximal end and mobilize very extensively the PAs, which are translocated onto the ventriculotomy. The main PA is then open longitudinally, and the anterior wall is reconstructed with an autologous patch. It has been described in the late 90s. Next. There are, of course, some indication for this technique with pulmonary annulus, which is severely hypoplastic, and the need for transannular patch. And of course, you need an anomalous coronary that crosses the right ventricular tract at or near the pulmonary valve on annulus. Otherwise, the distance will be too important between the PA and the infundibulotomy. I think we can avoid the LeConte maneuver in this technique as it has been described at the beginning, because the aorta is very dilated and can stretch the PA bifurcation. Despite the mobilization, we have seen in this technique stretching of the PAs and the risk of coronary compression. Next. The double barrel technique has been described quite at the same time. The idea is to make a ventricular infundibular incision, few millimeters below the coronary, and then you are going to resect the muscle band from this infundibulotomy. Then you are going to do a parallel incision in the anterior portion of the main trunk and join them distally in order to create a reverse flap, which is going to be sutured to the ventriculotomy. Of course, the incision's length will be a bit superior to the distance between the pulmonary annulus and the infundibular incision in order not to compress the coronary. The anterior wall is made again by a pericardial patch. Next. So In this technique, the diameter and the length of the PA will give the length and the width of the patch. So if you have a very tiny main trunk, it will be difficult to do the double barrel technique. Again, if you have a very long distance between the coronary and the annulus, it will be quite difficult to deal with the repair. And I would recommend in this technique to do a very aggressive treatment of the native outflow tract with commissurotomy and muscle bound resection. Then you will get two nice outflow tracts from the right ventricle. Next. Coronary mobilization. I'm not very confident with this technique, even if my training started with this. I mean, the right ventricular outflow tract reconstruction is made under a mobilized coronary. You need probably a very old patient and a tortuous coronary to be able to do this extensive mobilization of a coronary and the placement of a transannular patch just beneath the coronary with a slightly undersized transannular patch. Of course, you can easily understand that you can get stretching very easily of the coronary, and this is quite difficult to manage probably with the younger patients. Next. For this reason, some author has described the possibility of right coronary translocation. The idea is to detach the right coronary from the LAD, reimplant it on the aorta, then you can make a transannular patch. I mean, it's quite easy to understand that it's probably feasible for adult patients, but definitely not for the youngest one. Next. So now I would like to emphasize the transatrial transpulmonary repair and its variants. It has been described a long time ago, but I mean, the Melbourne group was one of the team that published the first significant series about this technique. The idea is to close the VSD through the right atrium and then do the transatrial resection of the infundibulous stenosis. In this very specific case, you have to be very careful not to go outside of the right ventricle, because I mean, you can be very close to the abnormalus coronary and be in trouble to repair and close that hole. The resection for them includes the filling of the anterior wall of the infundibulum. Next. Then comes the right ventricular outflow tract time. The idea is to make a longitudinal opening of the main PA and then commissurotomy of the pulmonary valve, muscular resection through the pulmonary valve. In case of a very hypoplastic pulmonary annulus, you will make an oblique opening of the annulus and the infundibulum, following the coronary towards the septum, and then insert a transannular patch. In neck care, we like very much this technique, but we do, we add a tiny ventriculotomy, about 1 centimeter, to just below the coronary to undermine the muscle beneath the crossing artery. Next. Sometimes we find it very difficult to do it from the main pulmonary trunk, and we are very careful not to damage the posterior wall of the anomalous coronary. Some people like very much to dilate the pulmonary annulus with a balloon, like it has been described by Stellin. I don't think this is a very good option in this situation, because you can get very easily a stretch of the anomalous coronary artery. Next. Next, please. Next. Sometimes this is extremely difficult not to get any gradient, muscular gradient, just beneath the abnormal coronary. And then we don't hesitate to add a very small RV2PA conduit, usually a non-valve PTFE conduit, which allows normalization of the right ventricular pressure, and that will diminish the right ventricular hypertrophy and probably have a muscular stenosis. It can be suppressed later with recurrent muscular resection and allows sometimes to keep very small annulus. Next. So here it is now, the Necker experience. From 2000 to 2016, about 80 tetralogy of fallow patients with abnormal coronary arteries has been operated out of 1,000 fallow. I mean, the mean age at operation was 8 months, and you can see that the youngest patient were only 2 months, something which is really different from the Melbourne experience, who had older patients. 17 patients had previous spallation compared to 9% in our entire cohort of fallow, something that is different again from Melbourne, who had about more than 50% of previous palliative surgery. Next. So what is our palliation strategy? So we don't want to do that surgery before the age of 2 months. So we are going to palliate the youngest patient. And of course, we love RV to PA connection in the general fallow. But in that specific situation, we prefer, of course, Blalox, not to damage the coronary. We have very little experience with the stenting of the right ventricular outflow tract. And it has been a nightmare to excise the stent at repair because you have a huge scar just beneath the right coronary. It's very difficult to deal with. So I would not recommend that strategy for this specific patient. Next. So more than 50% of this very specific cohort of patients had a preserved annulus in Necker. I think there is a very good advantage of to add a microventriculotomy just below the abnormal coronaries, because it's easy to resect the muscle beneath the coronary, and then you won't accumulate gradients beneath the anomalous coronary and at the valve level if there is a small annulus. And if you compare to the Melbourne one, they have only a quarter of patients with a preserved annulus at surgery. And it helps again if you have very young patients around 2 months, 3 months to do that surgery too. Next. So what are the results with this transatrial, transpulmonary, with or without small ventriculotomy? The results are quite good with a very low reoperation rate. About 95% of patients are free of reoperation at 5 years. And it's quite the same in the Melbourne and Paris group. Next. If you compare now to fallow that have been repaired with RV2PA conduit in the Boston experience, there is a tremendous difference. And even if you compare just the fallow with abnormal coronaries that have been repaired with a transatrial approach or ventriculotomy approach, it's really far away from RV-PA tube repair, like has been published by Marina Long in 2012. Next. So what are the reintervention risk factors in our experience? Yeah, of course, right ventricular LV ratio was higher in reoperated patients. But there are quite many patients who had a significant RV to LV ratio at repair that didn't need reoperation at some time. So I think the nature of a gradient is probably more important than numbers. And I like to have a TOE for this patient in order to visualize where the gradient is and what is the nature of this gradient. A muscular gradient beneath the anomalous coronary artery, or just a gradient in a small pulmonary annulus with a very thin down. Next. Late reintervention now. There are very clear guidelines about what to do before surgery. You have to know where are the coronaries before surgery. And it means that probably you will have to do a CT scan before surgery, even if you have very precise operative notes. It will probably decrease the risk of reoperation because it's quite difficult with a scar to see where are the abnormal coronaries. Next. Some of the patients will need percutaneous pulmonary valve implantation. And you need to know that there is, of course, a higher risk of coronary compression. And it's most of the time an LAD from the right coronary. The risk is about 22% in these abnormal coronary arteries versus 2% for normal coronary arteries in fallow. So most of the authors will point out that a systematic coronary artery compression testing needs to be done before percutaneous pulmonary valve implantation. Next. So in conclusion, I would say that abnormal coronary artery is not a very rare situation. And the pre-op diagnosis by echo is very useful to adapt probably the team before surgery. The repair with a conduit can be avoided most of the time, and the transatrial transpulmonary repair is very effective in most of the anatomic situation. But you have to convince yourself that conduits are not less dangerous than a transatrial transpulmonary repair. You just delay the risk for the patient and increase that risk in the future. Of course, specific training is mandatory to obtain the ideal result in this very specific situation. Thank you very much for your listening.
Thank you very much, Olivier. It's a pleasure to have you, and thanks for your time. I know that most of the colleagues were involved in surgery, and they found a spot for this time with us. Grace, you want to say something?
Just that it was amazing. Thank you, Sasha, for having all of these amazing speakers together and think about the topics for this talk. And guys, we're going to have surgery part 2, and September, it's going to be amazing again.
Thank you, everybody. We will see tomorrow, but we will see soon with other appointment. Thank you, Olivier. Thank you very much. Really appreciate it.
Thank
Professor
you, guys.
is still there, but I don't know, the camera